the host, could you start? Thank you. Start the recording for me, and apologies for forgetting. As we talked about yesterday, Medicare Advantage coverage is through private contracts that the companies have with Medicare, and these are annual contracts. So we talked yesterday about the fact that some folks find that the company that they had insurance with made a business decision not to continue next year. So that can happen, right? So we talked about folks down in Lewiston and Clarkston that had a plan they really liked, and then Regence or Premera just decided we don't really, it doesn't make sense for us to continue to offer that insurance in this place. And so we have some, really angry and upset people who are calling and saying, how come I can't have Regence because I live in Columbia County or Stoughton County, but my cousin who lives in King County can continue to have Regence? Well, that happens. That's a business decision that a private company made about your insurance, but it feels, kind of traumatic when they just say, we're not doing this anymore, choose another plan for January, but that's real. Okay, last part of knowledge-based objectives, then we want you to be able, at a high level, to be able to understand how to learn and explain to your clients how they can research what their covered benefits are, limitations and exclusions, and that usually this means reading the plan documents. So we're going to encourage you to coach your clients to get past the headlines or the marketing and really read about the benefit to which they're entitled. There's just lots of just plain misunderstanding that people think that they read hearing benefit and they imagine that means they can get a hearing aid, for instance, from any provider that they want. And that's typically not how it works. Okay, and then back to my earlier observation about changes that happen. Enrolled members are required, plans are required to send what we call annual notice of change forms during ahead of the annual open enrollment period in the fall, as well as things like significant changes in the provider network or the formulary for covered drugs. And of course, our challenge there is people, holding on to those, understanding them, reaching out for support if they're not sure. And we won't have a practical experience of using the Medicare Plan Finder tool today, but it is the best way for people to research their options and enroll themselves, or we can help to enroll them into coverage or change their coverage. So in terms of skills and abilities, again, understand your own situation, which you all have this well in hand. So as Kendra observed, you all very apt pupils. Be able to explain the difference. We talked about this a little bit yesterday about how will people know to choose, how will people understand, how will people compare and contrast. So the main thing, again, for today's program is just they're different and they're exclusive systems of care. And so people just need to understand kind of at a very high level that this is a very different, right? These are managed care plans operated by private companies, and that way it's a very different kind of insurance, right? And then you will learn at least a little bit today about comparing options, and it's going to be about using the Medicare Plan Finder tool, and then reading those plan documents that you're going to hear me refer to as the evidence of coverage document. So again, read past the headlines and understand explicitly what the plan is promising, because effectively it's a contract, right? That evidence of coverage is a contract between you and your insurance company. Okay, so that's a lot. That's a lot to learn. Let's talk about eligibility for Medicare Advantage plans. This is going to look a lot like the slide you saw yesterday relative to Medicare Part D or drug coverage. The significant difference here, I'm looking at bullet point number 2, is that to enroll in a Medicare Advantage plan, you have to have Medicare Part A and Medicare Part B. So yesterday we said that you could have A or B to get a Part D plan. Today we're saying you have to have A and B to get a Medicare Advantage plan. And then again, live in the service area, abide in the rules, enroll on time. So whereas yesterday we talked about A, B, D, we talked about the initial enrollment period, today we're going to talk about the initial coverage election period, or the ICEP. The reason that this is different, again, is because Medicare Advantage plans are a different kind of insurance, and because you have to have A and B in order to get one of these plans, right? So Part D with A or B, but Part C with A and B. So it's going to be a little bit like the initial coverage period that we talked about yesterday, right? Yesterday we talked about the 7-month period that surrounds your 65 birthday month. So in the same way, it has the same starting date. So it starts 3 months prior to when you have Medicare A or B. And then the ending date is where it gets a little bit tricky. So it could be the last day of your Medicare Part B initial enrollment period, or it could be the last day of the second month after the month in which they're first entitled to Part A and enrolled in Part B. So what we're saying is that it might be that you're going to sign up immediately at age 65, right? So again, we talked about like no break in coverage. So it might be that you sign up for your Medicare Advantage plan during the 3 months before your 65 birthday, so that your benefits for your Medicare Advantage plan start the first day of the month. Or, as we talked about yesterday, a lot of people are going to wait to sign up for Medicare Part B because, for instance, they're still working and they're covered under a group plan, and Randy shared his experience. So in that case, what we're saying is you can wait to sign up until after you retire and start your Medicare Part B benefit, but you're still limited to the 60 days after that time, right? So what we're saying is it has the same starting, it's still the same 3 months ahead of your birthday. It might have the same ending, but it might be that you have a period of 60 days after to get enrolled. So we're going to talk about that in some more detail. But this expression, initial coverage election period, is meant to distinguish it from the initial enrollment period for ABD. So as I said at the outset when we were going through the learning objectives, you cannot have a Medicare Advantage plan that includes prescription drugs and then buy a standalone Part D plan. So you're going to be either in original Medicare or Medicare Advantage, but not mix and match, right? How do you enroll? Enrolling is, again, pretty simple, right? So lots of different ways to enroll. So as a beneficiary, you can enroll at the Medicare website, which is what I'm going to obviously recommend to people who have technology access and technology skills, because you can use that Plan Finder tool to compare all your options in detail. You can call 1-800 Medicare and they can enroll you into a plan. You can call the plan that you're interested in and just literally enroll on the phone with a licensed agent that represents that company. You can use the website for the plan. So if you think you want insurance with WellCare, you can go to the WellCare website and sign up directly from there. You can call us and we will help you to enroll. Again, with your consent, we would hop on the Medicare Plan Finder tool, ask you some questions, and enroll you. Or you can also obviously reach out to a licensed agent or broker, and generally they earn a commission for helping you to enroll. It's free to you, so they're paid by the company for the service that they provide. So lots of different kinds of ways to get started. And again, for today's program, we're really focused on people who are turning 65 and getting started, compared to all the kinds of things that happen during open enrollment, which we'll pick up on a subsequent program. So how about covered benefits and costs for Medicare Advantage plans? So the main takeaway is that it's very difficult to generalize because they are all so very different in so many different ways. So first of all, it might or might not include drug coverage. It might come through the commercial market, which is our focus for today. But as I said yesterday, about half the people that have Medicaid are in Medicare Advantage plans. About half the people who have retiree coverage are in Medicare Advantage plans. The plans that are offered and the benefits and the premiums can be different county to county. Oftentimes, one company will offer many different Medicare Advantage plans. So you might see that there is, for instance, United Healthcare offers 10 different kinds of Medicare Advantage plans in King County. That's very common. It's also true, as I said, that with prior notice, the companies can change the list of covered drugs or the list of providers. And the benefits can also include a wide range of, the technical term is supplemental benefits. So we're talking about things like the company saying we offer transportation or over-the-counter card for drugs or a wellness benefit. So there are these other kinds of benefits that are above and beyond Medicare coverage, and they just vary so widely, company to company to company, and place to place to place, that it's very hard to say, in general, Medicare Advantage plans look like this, or they cost this, or this is the package you're going to get. It really takes a fair amount of research to understand all the details. So again, back to my graphic from the Medicare and You handbook, we're talking, when we talk about Medicare Advantage plans, we're talking about this system of care, also known as Medicare Part C. You might still hear people refer to these as Medicare Plus Choice plans. They were branded like that back 20 years ago. And in general, again, all of your Part A, Part B benefits are part of your package, generally Part D and oftentimes other extra benefits. So again, to put these plans in context, we're talking about private plans that contract with the Medicare agency, and those plans in turn negotiate with individual providers about how much the providers earn. So whereas on this side, we're talking about there's a fee schedule between Medicare and the doctors or Medicare and the hospitals. On this side, what the doctors and hospitals earn is dictated by a contract they have with the Medicare Advantage plan. And of course, that's lots of the headlines, right, that you read about where United Healthcare and Franciscan Virginia Mason are not sure that they want to continue to work together, right? That's all about the rate that the providers are getting from the insurance company. And that's something that they work out. Medicare has a very hands-off approach to those kinds of conversations, and it's beyond our jurisdiction as the insurance commissioner's office. So we're really just helping people understand their options, but we're not engaged in those negotiations at all. So here's the slide that I had up again yesterday where I'm saying that direct enrollment in MA plans is also inclusive of folks who have insurance from their job or from Medicaid. And then here, again, just as my sort of matrix where I'm saying that when we talk about Medicare Advantage plans, they may or may not have Part D coverage, and they may come from one of these three different kinds of markets. Okay, so how about premiums? It is often a surprise to people because they will hear or see that I can get ABC Medicare Advantage plan for no premium, and what they think that means is no premium at all. You're still paying your Medicare Part B premium. So again, as a condition of enrolling in a Medicare Advantage plan, you have to have Medicare Part A, you have to have Medicare Part B, so you're going to pay that Part B premium regardless. If the plan has a zero premium, you're still paying the Medicare Part B premium. Now, having said that, there are still today in the market some plans that will offer, like they'll give you back, they say give you back part of your Medicare Part B premium. So as like a supplemental benefit to your insurance, they'll say, we'll give you like a rebate of $50 towards the cost of your Medicare Part B premium. They are allowed to do that. Beyond then the Part B premium, the premium for the plan, most of the costs that you're going to have as a Medicare Advantage enrollee are what I would call, again, those like point of service costs. So the cost you pay at the pharmacy or for mail order, the cost that you pay when you go to the doctor or the hospital. So it'd just be important for people there really is no such thing as a zero cost Medicare Advantage plan. There is such a thing as a zero premium plan, but that doesn't mean that it's zero total cost. And believe it or not, that can kind of come as a surprise to people. So again, for today's program, I'm talking about commercial market plans. I'm going to do Medicare Advantage plans first, and then I'm going to do Medicare Supplement plans. So generally, I'm calling Medicare Part D and Medicare Part C Medicare health plans. So as with Part D, there's a market rate for these plans, right? That's the rate that the companies are selling it for. And for some people, they can have a reduced rate depending upon if they qualify for, again, I'm going to say Medicare savings programs. So programs that the states offer that pay the Medicare Part B, like Boyd premium, or for Medicare Part D, folks who qualify for what I'm calling the low income subsidy or extra help. So you may pay a lower premium for plans, Medicare Advantage plans that have a premium, or you may have a benefit that doesn't cost you as much at the point of service because you qualify for the low income subsidy. And we're going to talk about both the MSP and the LIS programs in greater detail at the end of the program today. But the point here is that the premium you're paying, if you have one for your Medicare Advantage plan, is being paid not to the government like your Part B premium, but it's being paid to that private insurance company. So again, just a quick review, and I did talk about this yesterday, but we talked about a lot of things yesterday. There's a lot of uncertainty sometimes and confusion about Medicare pays for this Part A covered benefit or this Part B covered benefit. Will my managed care plan, will my Part C plan pay for it? They have to pay for it if it's a Medicare Part A covered benefit or a Medicare Part D covered benefit. But they are allowed to, again, come in with these managed care things like a prior authorization or like a referral. And there are benefits that they offer that are not part of the Medicare package. And so what you want to do, as I said yesterday, is it's absolutely possible to ask for a coverage determination before you get the service. So you can literally ask your provider and your insurance company to say, I'm thinking of having XYZ procedure done at ABC facility. I want to know, is it going to be covered and what will my liability be? They're required to do that for you. Okay, so again, largely this is going to be a review, but these are managed care plans. They're private insurance companies, and they do offer more benefits than original Medicare, but the details about what's covered and what your liability is, and then exclusions and limitations are something that it's your responsibility as the buyer of the product to make yourself aware of. Okay, this is a screenshot from the Medicare Plan Finder tool that I keep talking about but not showing you. So at the first step in the process, before we get to comparing plans, they're asking about, do you receive any form of financial assistance? And the reason that we're asking about this is because for people who qualify for Medicaid or Medicare Savings Program or Extra Help, then the result set that's going to come out of the search that you do on the website is going to show you both plans that are only available for low-income people or plans that are available to everyone in the market, but the benefit design, including what you pay for the cost share, premiums, deductibles, copays, can be different. So it's important for people to know whether they qualify for assistance. And as a SHIBA volunteer, again, as I said yesterday, what we want you to do is ask people if they're receiving assistance, and if not, to have a couple of questions to determine whether it's worth encouraging them to apply for assistance, and then potentially helping them to do that. So it's in scope for you as a SHIBA volunteer to actually help them apply for assistance. And we'll talk some more about that in the last part of the program today. So there are different kinds of Medicare Advantage plans. This is a screenshot from the Medicare website. So in general, Medicare charters 5 different kinds of Medicare Advantage plans. In Washington State, we only have 3 different kinds. So in Washington State, we have HMOs, PPOs, and special needs plans. We don't have medical savings accounts nor private fee-for-service plans, but we do have HMO, PPO, and special needs plans in Washington. So let's talk about a quick review then about kind of the differences among and between those things. So a special needs plan means that only certain people are eligible to enroll into that plan. And there are a couple of different kinds of special needs plans. The one that you're going to commonly encounter in Washington State in your work is this one that we call a DSNP plan, or a dual eligible special needs plan. So when we get to the last part of the program today, again, we're talking about a dual eligible person is someone who has Medicare and Medicaid. So they're enrolled into both systems, Medicare and Medicaid. And just a reminder that because of the way these plans are chartered, provider networks are a very big deal. And you want to just make sure that you understand the rules about in-network and out-of-network and how that affects your liability. Okay, so here again, quick review: Health Maintenance Organization, or HMO, HMOPOS, or HMO Point of Service Plan, and then Preferred Provider Organization. So an HMOPOS plan is a bit of a hybrid, or it's in this imaginary middle space between HMOs and PPOs. So I want to take a minute and sort of talk about each one of those, again, just like at a very high level, okay? So let me, if I can manage the technology, I'm going to hop you over to the Medicare website so we can see how CMS explains what an HMO is. And I probably have to do something different with my screen, yes? Bear with me here a second. Shannon, did we move over?
Yes.
Okay. So I'm just you can see at the top, I'm at the Medicare website here, and we're talking about explain to me about Medicare Advantage plans, and specifically an HMO plan. So HMO, again, is sort of acronym for Health Maintenance Organization. And you can see this is what they're going to say about health maintenance organizations. And specifically what we want to do is acknowledge that mostly what distinguishes an HMO from an HMO POS compared to a PPO is about the network of providers. So what we're going to say here is about, can I use any doctor or hospital that accepts Medicare? And the answer is no. Medicare says sometimes, Tim says no, you can't. HMO is going to be, I'm going to describe as like the most restrictive kind of plan. In general, if you don't see a provider that's in the HMO network, it's not going to be a covered service. So this can be a little bit tricky for people because they don't necessarily understand the difference. And so when they're working in the plan finder or when they're talking to an agent, they want to be really clear that if you choose an HMO type plan compared to a PPO type plan, that it's going to have very different consequences for you in terms of using providers outside the network. We're talking about the difference between that you might pay a little bit more compared to you will pay everything because it's out of network. So how I would want you to think about HMO is it's the most restrictive. Generally, you're going to use a provider in the network, or you're going to need a referral, or it's simply not going to be paid for. And not paid for by the plan means, number one, it's your liability. And number two, it means it's not counting towards your maximum out-of-pocket cost. So if the plan has a limit for what your ultimate liability is for the plan for the year, we're not counting those costs for services that you had that were not covered or that were out of network. So it's it can feel like a little bit of a detail, but we want people, again, because there could be 10 United Healthcare plans in King County. Are you thinking about an HMO plan or a PPO plan? And make sure that you understand the difference between the two kinds of plans. And let me just stop there. I've been talking for a long time. How about questions about what we've covered to get to here before I kind of pivot and talk about PPO Medicare Advantage plans? Do I have anyone in the room who has a Medicare Advantage plan and the kind of it is an HMO plan compared to a PPO?
I do.
You do. Tell us.
My first year into this, I was on an uh, Advantage plan PPO. Then I got notices about the changes on that, and my broker reached out to me and said, I have a better plan for you. It's the same carrier. It's an HMO. So I I don't know what changed. The providers that I currently have are still on this plan. Um, Instead of $40 a quarter for extra fund money, I get $50 a quarter for extra fund money. Uh, but so yeah, I'm on that, and I hope that I don't have to face anything outside of the network.
Perfect. But you understand, your broker helped you understand the difference.
Yeah, not as clearly as you did.
Okay. Well, okay, that's fair.
So I'll call
Fair.
you next time, Tim.
Yeah,
Thanks.
absolutely fine.
Yeah.
Doesn't your main provider manage your health care? So in other words, you can't just choose to go to a specialist on your own. You must receive a referral from your primary care provider.
100% yes, Karen. Mm-hmm. And I think that would be, for me, that would be one of those things that I would want your agent or broker to make clear to you. And they might or might not do that.
Right. And mine did not.
Mm.
I'll bring that up to her.
Yeah, I mean it's yeah, I mean there you might hear like the expression like gatekeeper, right? Like they're managing your referrals either to a different provider or outside the network. Having said that, I do want to make the distinction that whether it's an HMO POS or PPO, emergency services are always going to be covered. So we're really talking about non-emergency services. Okay. I should just check the chat to see if I missed anything. I missed Rosie. Okay, so I don't see anything in the chat. Let me see if I can come back to my slide deck then. Rosie, are we back to the slide deck?
You probably didn't see me giving you a thumbs up. Yes,
I was distracted.
you are on the HMO POS slide.
I went to Centralia a week ago or so, and there was a woman there that had the strangest looking dog I ever saw. It was a cross between a German Shepherd and a Basset Hound.
Oh my gosh.
And it looked exactly like what you think it looked like.
It was
It was like
adorable.
long and low, close to the ground, like a Basset, and it was exactly like a German Shepherd that had been like, you put it in the dryer at the wrong setting. Yes, Rosie, I was distracted thinking about Mud the mixed dog instead of seeing your hand signal. Okay, so how about HMO point of service plan then? So some HMO plans, this is not common, but it does come up, and I'm mostly sharing this with you today because what inevitably happens when you're counseling people, especially when you're counseling during the open enrollment, is right, they're very agitated, right? There's a lot of emotion, there's a lot of anxiety, there's a lot of confusion, and so they will fixate on details that are not relevant. You'll be showing them the Plan Finder tool, and they're going to say, "Oh, HMO POS, I don't know what that is. I've never heard of that before." It's not relevant, but that you will not be able to go forward unless you answer their question. So this is what HMO POS means. It means that in some cases, you can see doctors or use other kinds of healthcare providers outside the network if you're willing to pay a little bit more. So this is kind of the companies trying to have kind of the benefits of an HMO from their perspective because it has stronger cost controls or stronger utilization measures, but also appreciating that a lot of people don't want to feel quite so restricted. So it's a way of kind of competing with straight up PPO plans. And so with that, let me show you this fun Medicare publication. I hope the computer's going to go with me. And I remember to change the screen back. Okay. In general, I'm a bit of a critic about the publications that Medicare makes. But I think this one's pretty good. I think it's probably better for you as a volunteer than it is for the general public. And let me just, I can put a note in the chat so you can just put it up on your screen if you want, or follow the link later. But this is a publication that Medicare put together called Understanding Medicare Advantage Plans. And they are going to try to, in this publication, explain the difference between these three kinds of models. And so let me see if I can, it's towards the back, if I can find my way over there to show you how Medicare describes the difference between these three kinds of plans. And this is obviously going to go farther than what I'm prepared to cover today. So I think I just missed it. Okay, so this is the Medicare definition of an HMO and then what an HMO POS plan is like. So they're saying you can get some services potentially from an out-of-network provider, but you're likely to have to pay more. And again, like I say, I'm a bit of a critic. What I wish they would say is that in general, that means that your primary care doctor approved it. So we're not talking about like self-referral to an out-of-network doctor. We're talking about you had a referral from your provider because in their view, it was a medically necessary service. Okay, so as I say, obviously I'm a bit of a critic, but you know, I think it's fair play to acknowledge that a lot of our clients are, you know, obviously using the internet, using Medicare resources. So they feel like better for you to be aware of what they might be encountering, at least from Medicare, so that you have a context for the kinds of questions that they're bringing. And it's not a horrible publication. It's among the publications that Medicare has, I like that one relatively better. Okay, easy for me to say. People in glass houses, right? Okay, so I'm gonna try to get back to my slideshow again. Rosie, I'm ready for your hand signal. Are we all together? Or do you want to hear another story about another funny looking dog?
Oh, you've seen more than one?
Oh, they're bountiful. Yes, if you're looking for them, they're everywhere. Okay, how about PPOs then? PPO, obviously acronym for Preferred Provider Organization. So there is a network of providers, including doctors and hospitals and other kinds of providers. In general, you pay less if you go to a provider that's part of the network. In general, you pay more if you go to a provider that's out of the network. But you are allowed to use providers outside the network. In general, they're not going to be not covered services, but you should just be aware. And this, as some of you might know, this can be really tricky because you can't simply rely on like the provider directory that you see online and go off of that and assume that it's covered. And so, again, what we're going to counsel people in your role when you put on your Sheba Volunteer Advisor hat is essentially talk to the business manager at the provider office and don't say, I have United Healthcare, but be explicit about the plan ID for the plan that you have or that you're interested in, so they can tell you whether or not they accept that insurance and if they do, what you're going to pay for using them. But in general, PPO kind of the most permissive compared to an HMO or an HMO POS plan. In this next chart, I'm trying to explain again that in original Medicare, we have covered services that have patient liability. In Medicare Advantage plan, we have all the same covered services, but we don't use the same kinds of expressions, or we don't use them the same way, or they don't translate exactly the same way. So in a Medicare Advantage plan, you're still going to pay something when you go to the hospital, but it's not going to be what someone who only had original Medicare would pay. So the hospital admission may have a deductible, or it may have a coinsurance, or it may have a copayment, but it's not going to be the same as what you saw on the Part A, Part B chart, because it's something the plan negotiated with Medicare. Okay, so again, it's a not standard amount. A feature of all of the Medicare Advantage plans is, again, this is CMS regulation, there is a maximum out-of-pocket limit for the person who chooses the plan. Sometimes those can be partitioned to where there's one limit for drugs and another limit for not drugs. And anything that you have, whether it's prescription drugs or medical treatments that are outside of covered benefits or covered services, do not count towards that accumulation of your total costs. So for instance, Amy and I had a call this morning with a gentleman who has a Medicare Part D plan, and he said, so $2,000 annual out-of-pocket maximum, that's a lot of money. I went to the pharmacy and I was told that I could get the drug for less using my, I could go to Costco and get it for less than if I used the pharmacy, or I could use my GoodRx card. And does that then count towards my maximum out-of-pocket cost? It does not, right? So you just want to be aware that only things that count towards your limits are the things that the plan is paying for, or in other words, are covered services that the plan would pay for. So I talked a minute ago about this idea of an evidence of coverage document. I excerpted this from the Aetna website a few months ago. So what I'm going to encourage you to do, and I want you to encourage your clients to do, is kind of get past the headlines, get past the marketing, even get past this fun, glossy thing called the summary of benefits, and look for this thing called the evidence of coverage. It's going to provide a lot more detail, and it's going to be much more clear about how that works. And at the break, I will I'll take a note right now so I don't forget. At the break, I'm going to show you
Hello, it looks like Tim's computer froze. So he says we are on a 15-minute break. So we will resume at exactly, well, okay, let me get 16. So 2 o'clock on the dot.
Thanks, Rosie.
Uh-oh, I forgot to do my homework. Hang on a second. Got distracted. All right, friends, welcome back. I apologize, my computer ran out of its battery. Unfortunate. There was a warning, but I thought that meant I had 5 minutes, and I didn't have 5 minutes. So that's probably a life lesson for me. Things in the mirror are closer than they appear. I feel like I'm missing someone. I don't see Amy. My friend Amy went away. Okay. Eve, I just sent you a note on email, because I think you have email contacts for all of our folks that are in the meeting. What I'm sending you, asking you to forward, please, is an example from, I did this a couple of days ago or last night, from the Aetna website about the difference between what's included in their summary of benefits compared to what's included in their evidence of coverage document. And you'll know that they're different because one is about 30 pages and one is about 200 pages. That'll be your first clue that they're different. But just as an example of kind of that level of detail question about covered benefits, exclusions, limitations that I'm trying to describe would be if you were to take a look at how they describe in the one document compared to the second document, what your benefit is for hearing aids. And both are technically correct, but I feel like for a member who was considering enrolling or was enrolled, the evidence of coverage document is much more clear about what you have and what you don't have, or what you can expect compared to what you can't expect. So having said that, I'm appreciating that lots of us and lots of our clients don't have the time or the energy or the skills necessarily to navigate. But I think that as much as you're able to in your consultations with clients, to encourage them to ask for and read and use those documents, it can reduce a lot of the friction and a lot of the complaints and a lot of the aggravation that people have who have these managed care Medicare Advantage plans. So again, in the context of appreciating that that's a really significant thing to ask, I think it really is helpful. Okay, so again, apologies for abrupt break, and I'm going to see if I can queue up my slide deck again, sort of pick up where we left off. And okay, Rosie, we all good? Are we back on summary of benefits compared to evidence of coverage? Thank you. Okay, so I do want to talk about what, again, I mentioned this earlier, but one of the aspects about these commercial market Medicare Advantage plans is that they are annual contracts. It's a business arrangement between you as the member, the managed care plan, and the Medicare agency, the Centers for Medicare and Medicaid Services, CMS. So we did have, and some of you may have been personally affected or heard about this, in Washington State during the last open enrollment period, and again, this is what Amy and I were checking in about this morning, was we had a lot of plans in Washington State that were discontinued. So about 60,000 people in Washington got a letter saying, gosh, Susan, we've just taken a decision that we're not going to be offering this insurance in the place that you live anymore. So you need to find a different plan for January. And as you can imagine, that was super upsetting to people. And so in general, that took three forms. So In the case of Premera, they just decided that they're not offering Medicare Advantage plans in Washington State anymore at all. So everyone in Premera just got a discontinued letter. In the case of Regions, it was that we used to serve 16 Washington counties, and on a going forward basis, we're only going to offer these products in 5 counties. In the case of Aetna, it was that we used to offer 20 Medicare Advantage plans, and now we're only going to offer 10. So all of those people then got these letters that, you know, caused a lot of concern and fearfulness. And so we spent a lot of time trying to counsel those people about what their options are and what their rights are and how to kind of navigate making these changes. I'm sure we missed thousands and thousands and thousands of people that would have benefited from a consultation, but for whatever reason, we did not make that connection with them. My personal crystal ball is we won't have exactly that same phenomenon again next year, but we will have something very much like that we are just living through very turbulent times right now in terms of Medicare Advantage plans. And so we really have to be, from my perspective, in the business of helping people understand that this is a thing that could happen to you. And so please make sure, starting with like, check your mail, be aware. If you didn't get something, you might need to reach out to the company and say, is there anything I need to know? Because I haven't gotten a notice that I was expecting, and I want to make sure that I'm not caught off guard by things that are changing. If you got something and you're not sure what it means, you for sure should reach out and call us and help us, let us interpret that for you and make sure you understand explicitly what it means for you. And although it is, you know, difficult, again, appreciating the difficulty of it, really think about comparing plans at that very, you know, kind of granular level so that you don't misunderstand and think that you're buying into something that turns out not to be true. And this is especially true of provider networks. I'll tell you a story that happened this time. A person called me, and he lives down Southeast Washington. And his plan was going away. He had a Regions Medicare Advantage plan. And so he reached out to his broker and said, I would like to have another plan that's kind of like my Regions plan, if there's another kind of plan like that. And he got put into a plan that seemed like a really good deal. On January 6th, he went to the eye doctor and got told, we don't contract with that managed care plan. Oh, Kendra, am I missing something?
Before you moved on with the story, I wanted to let you know, Carrie had a great question. She asked, did Tim say 6 or 60,000 were impacted?
60,000.
That's what I thought. That's a big number.
20,000 for Regions, 20,000 for Aetna, 20,000 for Premera. A small handful for other plans, but those were the big. Yeah. So my person calls and he says, I just found out that my eye doctor doesn't contract with the plan, and it's very upsetting. And he called his agent and explained that. And then he had the idea that he better call all the other providers that he's used to seeing for himself and for his wife. And he found out that about half of them did not contract with the plan that he chose for next year, including, again, this is kind of a geography lesson, right? So he lives down Southeast Washington. The provider that he wants is in Coeur d'Alene, Idaho, sort of just east of Spokane. And it's because he has degenerative back disease and he needs to see a specific spine doctor, and they're out of network. So for the next year, he's either not going to use that provider, or he's going to absolutely run up to his maximum out-of-pocket limit. He's going to spend $11,000 out of his own pocket. And it's because he didn't understand the implications of making this change. So it's just meant to be sort of illustrative of the fact that there really are, you know, kind of big consequences for not understanding kind of how to navigate through the system. So, which is just my way of saying, again, thank you for embracing this opportunity, because you have an opportunity to help a lot of people, you know, either from your perspective, either like avoid a really bad thing happening, or really make the best of the opportunity that they have. It's because we're in for, as I said, another, I believe, really challenging open enrollment period in the fall. And I think that by starting now, you'll have ample time to learn a lot of skills and acquire a lot of knowledge that you'll be able to apply and you'll be able to help a lot of people as soon as the next open enrollment period. So looking forward to that. So what's happening right now? Well, we're going to, the Medicare agency, CMS, is making rules right now for next year related to things like provider contracts and marketing and the way that agents and brokers are compensated, and rules around things like artificial intelligence and hospital discharge planning. So we're still early kind of in the rulemaking about that, but there will be some more changes. And of course, there'll be the kind of annual changes that Medicare makes to Medicare insurance. So unfortunately, a lot of that isn't revealed until August, September, October. So we're a little bit in this kind of waiting space, but so our goal is to educate you as much as possible, to give you as many opportunities to practice, job shadow, work with other experienced volunteers between now and the fall, so that when the fall comes, we're building on kind of a strong foundation. But it's still going to be a lot of changes. So a little bit, we did this exercise yesterday, and I know some of you have Medicare Advantage plans and some of you have Medicare supplement plans. So can I ask for the folks who have, and Randy, you started to talk towards this, but if you're a Medicare Advantage plan person, how did you choose that? Why did you choose that? How is it working for you? What's your experience of it thus far?
Are you asking Randy?
And anyone who would like to respond, any of you all who have Medicare Advantage plans now.
I chose a Medicare Advantage plan, knowing full well about the network issues. In fact, I even called the providers that we go to and made sure they were in the WellCare network. And the premium for the plan that we had went sky, it really it went up. And so I really had to think twice. Well, there's one thing about Medicare Advantage, you have to be aware of the fact that when you go to the hospital, you do have copays for the first 3 days or so like that. And it's usually indicated on your benefit structure how much you have to pay. So you have to decide, do you want to accept that risk yourself, or do you want to pay more for a supplement or even another Medicare Advantage plan to pay for it for you? So, and I also have an issue with respect to critical access hospitals, but I'll talk to you about that later.
Okay, that will be a good conversation. We'll see if we have time today, but if not, you and I can talk offline.
Okay.
But I know what you're talking about.
Yeah.
And I'm happy to fill in other folks. Who else that has a Medicare Advantage plan want to share your kind of perspective or point of view based on your own experiences?
Well, I'm on a Advantage, like I said, and I did. I'm with United Healthcare. So after the shooting of the CEO, that was big news, and it made everybody go, "Wow, I need to look at my plan." And I didn't know United Healthcare declined coverage more than any other carrier. I didn't know that. So I was concerned about being with them. And I talked to the broker and she said, well, I said, maybe I should just go to Original Medicare and get a supplement. She said, you'll have to be underwritten and qualify. So that's a big consideration too. And I don't think I have any big things, but I might. And so I haven't jumped through that hoop yet. So I was curious, if you go back to Original Medicare, will you have to be underwritten again, or can you slip back into it?
In general, yes. And I'm not going to give you that homework assignment because that's a complex one. But let me, with your permission, let me do the program of Medicare supplement plans, and then let's come back to that question.
Oh yeah.
Yep, it's a great question, and it's absolutely got a lot of currency right now in terms of conversations that people want to have with us. And there's some complexity in it. Anyone else who has a Medicare Advantage plan that wants to share some experiences or insights?
I can share why I don't have one. I don't
Go
know
ahead,
if you
Judy.
want to hear it. Is it appropriate at this point?
Yes, please.
When we moved up here from Seattle, we decided to keep our doctors down there. And so the geographical restrictions on Advantage programs really worked against us. And the other thing is a lot of people in Bellingham go to the outpatient clinics in Skagit County. It's quite close. And they have better access there than they do up here oftentimes. The like walk-in clinics here are very hard to get into. And so, there was another county to deal with. And it's, the geography was just too hard.
Yep, it is. You have a lot of geography up there and sort of not enough providers relative to the number of people, right?
Right.
So yeah, when you talk about access, it's a lot about how long are you going to wait for an appointment? Yep. Yep. I think all the observations that you all shared, those are, I mean, it's really helpful that you can already anticipate the kinds of questions that your clients are going to take. Yep, that's exactly what you're going to get for sure. Yep, that's exactly what you're going to get. Okay, so as I said, for today, we're just talking about enrollment periods for Medicare Advantage plan, types of Medicare Advantage plans, and the idea that there are different ways to enroll, including using online tools. So we will come back in a subsequent program and talk a lot more about Medicare Advantage plans because, about 50% of people and growing will be at 60% in no time. Have these kinds of plans. And so I do want to come back and spend some more time and talk about, again, the plan documents, other enrollment periods. We have these things called special enrollment periods. Again, that would be the folks that got a discontinue letter from their plans. We'll talk about how these plans are different for people who have Medicaid or different for people who have insurance from the place that they worked. And obviously, we'll talk about complaints and grievances and appeals and define all those and talk about the support you can expect from us and our professional staff with helping people with those. And then, as Randy anticipated, talk about switching plans during the open enrollment or during other times. So still lots more conversations about Medicare Advantage plans. But with that, let me pivot and talk about Medicare supplement plans. So Medicare supplement plans are, really for most people that don't have Medicaid or don't have a commercial market plan, they're the significant alternative to Medicare Advantage plans. So when Judy said, like, we could do this or we could do this, and the cost of it, as Karen said, like, these are good plans, but they cost a lot more. This makes a good, like, compare contrast, right? On the one hand, MA plans, on the other hand, Medicare supplement plans. So again, lots of conversations to have about Medicare supplement plans. So let me share with you sort of the scope that I have in mind for today for this beginning basic training for Medicare supplement plans. So again, starting with learning outcomes related to knowledge, number one would be, again, these are exclusive systems of care. So you don't have a Medicare supplement plan and a Medicare Advantage plan. So Medicare supplement plans align with original Medicare. As with the Medicare Advantage plans, you have to have Medicare Part A and Medicare Part B. You can't have a Medicare Advantage plan and you can't have most kinds of Medicaid coverage. About Medicare supplement plans, the scope of them is limited to the cost sharing for services that are covered by Medicare Part A and Medicare Part B. So they're not as expansive as Medicare Advantage plans. They do not offer additional benefits. Enrollment, and we're going to spend a lot of time talking about this. Enrollment is both protected and restricted, and we have to talk about this concept of guaranteed issue rights, what Randy referred to as medical underwriting. We want to understand this concept this is some jargon, right? But the Medigap open enrollment period, which is different than the Medicare open enrollment period. But what is the Medigap open enrollment period, and why is that significant? I want to share with you some resources that we have as our office produced for you to help clients. Still more to go. I want to make sure that you understand that these are standardized plans that are sold by private companies, that the plans vary. So we talked about lettered plans yesterday and this idea of a plan F, right? So we call them by their letter, like there's a plan C, there's a plan F, there's a plan G. One of the things that people like about these plans, one of the kind of selling features of these plans is there's not a provider network in the way that there is with the Medicare Advantage plan. So they're not managed care plans. Because they're private products sold by private companies, the premium moves. That's a business decision that the company takes about the rate. These plans are regulated by both the federal government, again, the Centers for Medicare and Medicaid Services, as well as the state. And then there is this outside agency called the National Association of Insurance Commissioners that also helps the states and the federal government navigate regulating these plans. So we'll talk a little bit about how that works. And then number 13 is that although these are regulated generally, these plans generally are regulated by the federal government, each state has their own laws and rules that apply. And it's going to be important to sort of highlight some of the ways in which Washington laws and rules are different. In general, we have more consumer protections in some places than the federal laws. And then with that, let me switch to some of the kinds of skills that we're hoping you walk away from kind of this first program. So you can explain to a client that this is a different kind of insurance, that it in that matrix that I described about 4 parts, 2 systems, 3 markets, that you're able to explain to a client what the Medigap OEP is and the consequences for them of not enrolling during that time. And using one of our publications, and we have, again, very many nice publications about this, explain to a client using a Medicare Supplement Plan G as an example, the kind of coverage that these plans offer and what would still be their liability as a patient or a beneficiary. So again, this will be a relatively long program, and I'll give you a break pretty soon. Okay, so here's our familiar chart. And again, I'm abstracting from the chart to highlight here at the bottom that we say original Medicare, A, B, D for prescription drugs, and you probably want some other coverage. And then a Medicare supplement plan or a Medigap is an example. So again, these Medicare supplement plans align explicitly with original Medicare. They're not compatible with Medicare Advantage plans. So in general, hey, Kendra.
Hi, I just wanted to say Randy had a great question in chat. He asked, does the OIC have any regulatory oversight with the Advantage plans?
We don't. There's super narrow space. Basically, the federal law, this is paraphrasing, but the federal law says states butt out, that federal law preempts any state regulation, that the only space that the states have authority to regulate is licensing agents and brokers. So for instance, we don't regulate marketing, we don't regulate rates, we don't regulate company admissions to the market. It's all done at the federal, covered benefits, out-of-pocket costs, all done at the federal level.
So would the OIC get involved then if with coverage disputes?
We would not generally.
Oh,
so I need to make the
interesting.
distinction. Yep, I need to make the distinction here between where like the OIC as the regulator has authority compared to where the SHIBA program as kind of advocates or caseworkers where we would help you problem solve.
Right, but
Right.
so a volunteer wouldn't say you need to file a complaint with the OIC about this because it wouldn't do any good if they're
Right,
on an
so-
Advantage plan.
Right.
Interesting. Wow.
So what you would say as a volunteer is you need to file a complaint with Medicare.
Yeah. Okay.
and then we could help them sort of figure out how to do that. But you wouldn't file a complaint with us about your Medicare Advantage plan.
Okay.
Yeah.
Something
Yep.
else I didn't know.
Yeah. Yeah. And believe me, everyone who calls wishes that we could do that. But we can't.
Sure.
That's because that's what they think is like, oh, that's the business that you guys are in, is you regulate the insurance companies. And in
Right.
general, that's true, but not with these Medicare Advantage plans. But yes, with
Okay.
these Medicare supplement plans.
Okay.
Yep.
Thank you.
Yeah, of course. Thank you. And thanks, Kendra. Okay, so in general, again, when I think about other insurance besides Medicare, the couple of three things that people are trying to solve around is, what about benefits that are not covered by Medicare, including prescription drugs? And then what about things that are covered by Medicare, but they're not paid 100% by Medicare? So we're back to deductibles, co-insurance, co-pays. And so it's only the third thing, services that are covered by Medicare but not paid 100%, that Medicare supplement plans are in that space. So in other words, they don't include coverage for prescription drugs, and they don't include coverage for other medically needed services that are not covered by Medicare. So here's a graphic that's meant to represent that this big box represents all the things that you want to have insurance to pay for. And the only place that the Medigap is going to help is the part of the bill that Medicare doesn't pay for Medicare covered services. So no help with prescription drugs and no help with things like dental, vision, hearing. And so that's, among the first things that we want to impress upon our clients, is that it's a very different kind of insurance product. So let's talk about eligibility and enrollment. So like Medicare Advantage plans, oops, this is an error. This is supposed to say Medicare Supplement Plan. You have to have A and B. So apologies, I'll make that correction. But in general, be eligible for Medicare and then have Medicare A and B. You cannot have, as I said, incompatible with the Medicare Advantage plan. Some kinds of Medicaid are allowable, and we'll talk about this in the last program. Some are not, and you can't have more than one Medicare Advantage plan at a time. So how about getting started then? I'm going to describe this as like sort of your checklist. So you would decide which plan is the best one for you. You would decide which company is the best one for you. You would complete the application for that company, and then you would arrange for how you want to pay the company. And as I said yesterday, for folks who have a premium for Part A or Part B or Part D, I'm going to encourage you to suggest to that they not write a check every month, but instead they set up electronic funds transfer. The only way these plans can be canceled is for non-payment. So it's a shame when people get their coverage canceled just because they were delinquent. So it's just best to just let them take the money out of your checking account or savings account. So with that, let's talk about this sort of term of art called the Medigap. And Medicare Supplement and Medigap are synonyms, right? They mean the same thing. So a Medigap open enrollment period. So during the Medigap open enrollment period, you cannot be denied for any insurance that's available to you in the market. In other words, the companies have to take you during this time. And this time we refer to as the 6-month period that starts on the first day that you're both, so there's two conditions, the first day that you're both age 65 and enrolled in Medicare Part A and Medicare Part B. So it's a once in a lifetime 6-month period, and the clock starts on that 6 months when you're both age 65 and enrolled in Medicare Part A, Part B. So the next slide is going to sort of describe for you, I'm coming back to my persona of our person, Paul. So if Paul was turning 65 on April 6th, and he was wanting to enroll with no break in coverage, he would start his Medicare Part A, Medicare Part B on April 1st. So April 1st starts then his 6-month clock. So he would have between April and September and he could apply for any policy and not be turned down. That's his guaranteed issue rights or Medigap open enrollment period. He can continue to apply anytime after that, but as Randy suggested, beyond that period now, he's going to be subject to medical underwriting. The company is asking him to fill out a questionnaire about his health and healthcare and health history, and they may decline his application. They may say, we don't want you in our pool of covered people. So if Paul is motivated to get a Medicare supplement plan and he's concerned about his health status, he should do it in that 6-month period that we refer to as the Medigap OEP. So again, ideally, Paul's going to apply ahead of time, right? So although he has 6 months, if I'm counseling Paul, I'm going to say, the best time to sign up is before your Medicare Part A, Medicare Part B starts. You can simply write on the application, I expect my benefits to begin April 1st. I would like my Medicare supplement plan benefits to begin April 1st so that when the 1st of April comes, he has Part A, Part B, Part D, and he has his Medicare supplement plan in place. That would be, again, I'm making the distinction between on time in terms of no penalty or on time in terms of guaranteed issue rights compared to on time in terms of no break in coverage. So that would be the ideal case. Send your application ahead of time. Okay, so just a quick check-in because this can be a little bit tricky. When I say that there's 2 conditions that clock starts when you're 65 years old and you have Medicare Part A, Part B, sometimes here's I guess a couple of instances of where it can be tricky. So a person can be age 65 and miss it because they didn't sign up for Medicare Part B on time. Or a person can have Medicare Part A and Medicare Part B before they're age 65. So in other words, they're a younger disabled person. They don't have a guaranteed issue right when they first become eligible for Medicare, but then when they turn 65, they do have a guaranteed issue right. So I'm trying to say, like, sometimes you have Medicare Part A, Part B, but you're not 65. And sometimes you're 65, but you don't have Medicare Part A, Part B. So the clock only starts when both conditions are true. So I'm going to, again, ask you to kind of stand in that imaginary space where you're a Sheba volunteer. And the question that someone is asking you is, hey, from where I'm at today, can I get a Medicare supplement plan without medical underwriting, without a health screen? And the right answer would be, well, it depends. I need to ask you a couple of questions. So based on what we just covered, what do you feel like those are the questions you need to ask somebody? Anyone? A volunteer among volunteers? We're not judging you.
I hate to quit talking. I mean, I need to quit talking. I hate
You
to
don't?
always
No.
answer.
Talk away, Karen.
First of all, you need to know what their age is, whether
Yep.
they've turned 65 or are about to,
Yes. Yes. What else?
and how far how long ago did you turn 65?
Perfect. Yep, that's exactly right. That's what we want to ask about, because if you're not 65 yet, then you won't have kind of reached your guaranteed issue period, right? Or it may have already come and gone when you kind of didn't understand what that was happening. So that's exactly right. Yep, that's exactly right. You don't have to rein yourself in, Karen. You just come ahead. Okay, so it depends. Have you turned 65 yet, and when? And then when did you start Medicare Part B? Is that like, because we're talking about a 6-month space of time when you're going to be on time. So more sort of general knowledge about Medigaps, and again, this is a lot about like point counterpoint comparing Medigaps to Medicare supplement, or excuse me, to Medicare Advantage plans. Medicare supplement plan, Medigap plan works anywhere in the country. This is, again, one of those things people really like about it. So you can buy it in Washington, but you can decide that when you're in Arizona, you want to go to the Mayo Clinic and have your knee replacement done there. The insurance company, there's no service area the way there is with a Medicare Advantage plan. Any provider that contracts with Medicare will take your Medicare supplement plan. Once you buy a Medicare supplement plan, it's guaranteed renewable. So the company, again, by way of contrast, it's not like the kind of annual contract that we talked about for Medicare Advantage plans. As long as you pay the premium, they cannot cancel your coverage. And you will need some alternative prescription drug coverage because Medicare supplement plans do not include Part D coverage. So you're either going to need a Medicare Part D plan or some other form of creditable coverage because you won't be getting it through your Medicare supplement plan. So let me move ahead to.
Can I ask a quick question?
Of course, please.
Regarding the Medigap, is guaranteed coverage, but the rate term each year.
We said guaranteed issue.
Yeah, well, guaranteed issue, but also once you're in, you can stay in that until the day you die, as long as you'll pay the premium they determine at each renewal. Is the premium determined on your individual results, which may vary, or is it the group?
Come ahead, Linda, help us out.
It's the group. It's the same premium for everybody.
Okay, thank you.
And that's one of those ways in which Washington is different. So if you have already read, or if you're going to read the Medicare literature, you're going to find out that there's 3 different ways of rating or pricing these Medicare supplement plans. And Washington has what we call community rating. So if I buy it today as a 65-year-old, I pay the same rate as someone who's 75. And when I turn 75, my rate doesn't go up just because I became a year older or 5 years older. So it's everybody who has that product pays the same rate. So community rating. But that's not how it works in other states. In other states, we have different ways of doing that. So that's going to be a question that you're going to get, especially if someone is moved here. That would be the comment, like, but that's not how we do it in Idaho. You're right. Idaho has a different way of doing it. Or that they read, the Medicare website or the AARP magazine or Kiplinger's, and they read the federal rules about how rates are made, or they saw that language about like, this is the only time, if you don't buy it during this time, you may pay more later. That's not true in Washington. Community rating in Washington state. Yep, great question. So how about then, let me go back a slide. I did that too fast. So what is it gonna, let's do the costs and the covered benefits. And I'm gonna start with the costs and I'm gonna start with the premiums. So the premiums, again, vary by the company. So each company sets its own rate for its own products. The way that the rates are made and the way that the products that the company offer is regulated by Medicare and the state. And that's a good example about community rating. How Washington state does it is different sometimes than how other states or than the general kind of federal law works. So what it's actually going to cost you is going to be, again, about the company that you pick. The distinction that I want to make here compared to the program that we did yesterday and earlier today is that there are no contracts between these companies and Medicare. So all of the revenue that the companies earn is from your premium. And those premiums are not subsidized, nor is there penalties for late enrollment. So they're different than the way we talked about Part A, Part B, Part D. So there's not low income subsidy. There's not extra help. There's not a higher premium for higher income earners. It's a private contract between you and the company, and they're just making the rate that they need to stay in business that we approved. So I'm going to show you then, and I hope maybe we put this in your folder, but if we didn't, I'm going to show you on the screen and I'll put a link in the chat. This is one of our most popular publications for volunteers and Medicare beneficiaries. So we call this the list of approved plans. And again, I'm going to apologize. I'm going to scroll through this quickly just so you get a general idea about how many plans we're talking about. On the left-hand side then is the name of the company. On the right-hand side is the monthly premium. And so you see that
It's
a
not
relatively,
showing.
oh, thank you. Goodness,
Yep.
I forgot to do that. Thanks. Okay, let me try that again. How about now?
Yes.
Yes, thanks, Linda. So let me try that again. So this is our companies and plans that are approved for sale in Washington State by us. And then on the left-hand side, the names of the company and their contact phone number. On the right-hand side, then the products that they're offering. Again, we talk about these lettered plans and the monthly premium for those plans. You can see there's not all that many companies that are selling products here in Washington. It's going to be about 5 pages front to back. And this is, as I said, a really good resource for you as a volunteer advisor and for our clients about kind of navigating through doing this exercise. Again, I'm going to say, pick your letter, pick your company, apply to the company, and then pay your rate. So on page 26 in your workbook, let's do a quick exercise and then I'll give you a break. So the exercise is I'm asking you to, using the chart on the screen, or I put a link in the chat, I would like for you to please tell us for the product letter G, for 3 different companies. I picked Cigna and State Farm and USAA. I'm asking you to take a minute. I'll let you work here quietly and then tell us what is the premium, the monthly premium for that company for that product. So take a second to consider that, and then I'll ask to see what we came up with in the room, and time for me to make more tea.
Hey, Tim, real quick, do you mind clicking on the link I just shared? It'll show the January to March 2025 Medigap plans instead of last year's.
Oh my gosh, Eve, thank you. Yes. But then I have to do the share unshare thing, right? Did I get there, Eve?
Yep.
Oh, thank you for helping me. I'd be lost without you, Eve. All right, friends, I'm going to give you a couple of minutes to work on this. I'm going to go make some tea, and then we're going to come back and see what you came up with. Okay, I guess I wonder, that makes me wonder, did we give you the right handout, or did we have a handout that had the rate sheet in your binder or no? I can't remember now what we put in the binder.
I believe it should be the correct one, but let me know if I need to send out a new chart to anyone.
Okay. Does everybody who got a binder, did we put the rate chart in your binder?
Yes, you did. It's
Oh.
Where's
the
it
blue
at?
chart.
Where's it at in the binder?
It's in the back. It's a blue, it's on blue paper.
What page?
It's
Or
in
is-
the very last section, called Medicare Resources.
Looks
And
like
it's,
the right one.
it's like 3 pages on blue paper.
That's the right one.
Yeah.
And the ones you just recently sent
Thanks,
out.
Susan. We appreciate that. So I guess you have a blue colored one in your binder, and then I'll link to the screen that Eve put up, and I'll put mine back up on the screen for you as well. And let's see what you all came up with for, so I'm asking about the Plan G like giraffe and 3 different companies. So what rate did we come up with for Cigna?
$225.
I have 1 vote for 225. Does anybody have a different figure than 225? Or does 225 make sense to people? Susan says, yep, makes sense to me. Beautiful. How about for State Farm?
241.
241. Does anybody have a different number than 241? Someone thinks 242.
Oh, that's the old one. Oh,
242.
242. Sorry, I grabbed the wrong column. 242. Sorry.
242. And then how about for USAA?
235.
With 1 vote for 235. Anybody think different than 235? Okay. So this is going to sound funny, but we get a lot of questions that sound like, Tim, I don't understand. If you told me that it's a standardized insurance and that Plan G benefits are the same, why do the companies have a different rate? And to me, I think that's a funny question because everything else in the world works like that. So why would this be different? So you will, when in your experience as a volunteer advisor, you'll find your own way of explaining that to people. But again, I think it's just like it's so stressful, right? There's just so much anxiety that people just get distracted a little bit by details. But the main thing is it literally is the same insurance. When I was talking to someone recently about it during the open enrollment, I said, look, I recently had to go replace a pair of blue jeans. And so I just needed a pair of Levi's 501 button fly trousers, 34 waist, 32 inseam. And I looked on Amazon and they said they want this much. And I went to Costco and they want this much. And I'd go over to the mall at JCPenney, they want this much. But I swear it's the same company, the same factory, probably just cranking out denim trousers. And so the fact of the rate being different is not about the insurance, right? But people want to kind of, they kind of get stuck a little bit in the way, like, if it costs more, it must be better insurance, or it must have other benefits that the other one doesn't have. It's the same insurance. It's exactly the same. The company is just making a business decision, as Linda said, about this is our pool of people, and this is what we think their claims are going to cost. And that's the decision that they feel like is right for them. But it's identical insurance. A Plan G is a Plan G, regardless who's selling it. And honestly, regardless if it's Washington, Idaho, Alaska, it's Plan G is Plan G, right? That's what it means, that they're standardized lettered plans. So the difference in the rate is not about the product you're getting. Does that make sense?
Is there any information anywhere about whether, I mean, it's a company-based price setting, but about if they raise their prices over time, or with the stability?
Yeah, those are great questions, Susan, and you will get those questions as a volunteer advisor. Linda, you want to help me out here?
They can raise the rates once a year. And it's not always the same time, but they don't all do it at the same time. So but they can submit and get the rates approved and change them once per year. What was the other question?
Is there any information we could get to provide for someone showing the stability of certain companies? Some keeping things fairly stable or some peaks and valleys or.
You can go to there's financial reports on the companies like Moody's and AA, or is it AA or Best. We have a resource on our webpage as far as where you can go to get the financial information on the companies, but they are ranked and they're rated, and so you can tell if it's like an A+ company or an A, and occasionally um, they'll lower them, like some years after like a catastrophe where there's been a big weather event, you'll see that a company will lose a ranking, but oftentimes they'll pick it up. But you can also tell when a company is having real problems, because if they're down to like a C or something, it's not a good sign.
Can you switch from one company to another in the same plan? Like if you have G, can you switch from Aetna to Primera or?
Yes, and Judy, you are just right where I want you to be, just ahead of me. So you're just drawing us along in your wake. So you're perfect.
Okay.
Yep, we're gonna go there after the break.
Okay.
I have one philosophical question.
Yes, one per session. Go ahead, Susan. Don't squander it.
I'm guessing as a volunteer, it's our role to provide that ratings to someone but not say to them, well, this rating is a C and this is an A, so you should go with the A. I mean, it's maybe a stupid question, but.
No, it's a great question. And someone's going to ask you that for sure. So a couple of things, and this is not in the packet. So great questions. And I think Kendra said this yesterday and again today. You all are relative to other people that we've had in basic training, you are way ahead of the curve. You are an exceptional group. So you're taking us a little bit farther than I typically go in the class, but that's all for the good. So I'm just acknowledging that I'm not presenting that material to you because generally you're just far ahead of where we're at. So a couple of things then. So when I say that the OIC regulate these plans and these companies, we have people whose job it is to evaluate the questions like solvency. So, not to pick on Cigna, but I'm saying, okay, the rate for Cigna is $225. Is that company still going to be in business next year? We have people who examine the books for the companies to make sure that they're solvent. So we would not let them continue to do business in Washington if we didn't have confidence in them. So there absolutely is those kinds of rating services that Linda described, Moody's or Fitch or AM Best, and they're essentially evaluating that company, which offers lots of different kinds of insurance products, right? So we want to just make the distinction that that's like saying, pick a company that like John Hancock, right, or a bank like Chase. But that's not saying relative to these kinds of products, right? So, but with regard to these kinds of products, we're doing that evaluation all the time to make sure that you're not going to sign up for USAA and then a month later they fold, right? That we have that responsibility as part of our review. Having said that, if for some reason that they decided that we don't want to sell in Washington anymore, or that they ran up, they depleted their bank account, spent all their reserves, then in Washington state, we have this provision where you will be protected because you can immediately switch to any other company.
Oh.
So you won't be without insurance. So if you, again, I do not mean to pick on Cigna. There just happened to be in my sample workbook. But if we were wrong and Cigna went out of business and just said, sorry, we can't pay our claims anymore, you would be protected. Your claims would be paid. We have like a reserve fund among all the insurers, and then you would immediately have the chance to go to a different company. So it's really like a risk-free purchasing decision in terms of the solvency of the companies.
So if they decided to not offer G anymore, would you still be able to get G somewhere else?
Yes.
Okay.
Yep, for sure. Yep. I want to take up that question about switching when we come back from the break.
Right.
But I want to give you a break. You've earned it. Good work. So how about let's take 15 and come back at 3:15, and then we'll finish our work on Medicare supplement plans and pick up our work on financial assistance programs. Thanks, Linda.
Oh, you're welcome.
All right, friends. We ready to pick up again? Still more, different, better. Drop my pen. There's my tea. I got my teacup. I'm all set. Hey, so let's. I gotta get a slide deck. Can't work without a slide deck, right? And catch up to myself. We did that. We did that. We did that. We did that. That was great. Okay, where is who are my helpers? Kendra, were you looking at the slide deck again? Am I sharing my slide deck with you?
Which Kendra?
Oh, good question.
The answer is yes. You are. You have what is a Medigap plan?
What are the odds that I have a meeting with two people named Kendra in it at the same time?
Not great odds.
Not great.
And my source is my lifetime of experience.
Yeah, right. Okay. So Medicare supplement plans, also called Medigap plans or MedSup plans, again, sold by private insurance companies. They're so-called Medigap plans because they pay for the gaps in original Medicare, so the part of the bill that Medicare doesn't cover, which includes deductibles, coinsurance, copays. So yesterday we talked about Medicare Part A covered services, Medicare Part B covered services. So we had this on one side Part A, on the other side Part B, and then what Medicare pays, and then what you would be liable for. So it is these things, deductibles, coinsurance, copays, that we're talking about that Medicare supplement plans are going to take care of. As I said, these are standardized plans, and we call them by their designated letter. So in Washington State, we currently have A, B, C, D, F, G, K, L, M, N. And there's a little asterisk because C and F are only available to people who were age 65 before January 2020. There are people who have plans of the kind that are the so-called missing letters. And again, because these are guaranteed renewable plans, the company cannot cancel them. So you will find people who had a plan H or a plan I or a plan J. Those are still out there. And as long as people continue to pay their premiums, they are allowed to keep them. Now, the companies and the agents and the brokers are generally trying to advise them to move into one of these other standardized plans, but they're absolutely allowed to continue with those plans. I want to talk just for a minute about Plan G. G like giraffe. G is the most comprehensive plan, and it's the most widely sold plan. And so I'm going to use that as the basis for the conversation about kind of comparing the plans a little bit. So what I'm trying to say is I'm not meaning to imply that it's the best plan. It just gives us a natural starting place to compare to the other lettered plans. So I'm going to practice a little bit with you. Again, I'm going to use that same publication. Have to ask again, now embarrassed, but the blue colored sheet, does it include at the last page a grid that says like these plans cover these benefits, or is it only the rate sheet?
Has the benefits.
Has the benefits. Excellent.
On the
Okay.
on the very last page on the back.
On the very last page. So helpful. Thank you.
Mm-hmm.
That is so helpful. Thank you. So let me see if I can share my screen with you. Again, always a little bit of a feat of daring. So Linda, does my screen look like the last page of the blue chart?
Except that it's not blue.
Except it's not blue. Okay.
But otherwise, it's the same.
That for me is like about as close as I'm likely to get the sameness. Okay, so again, using Plan G as an example, again, not meaning to endorse that plan compared to the other ones. But the way to read this chart, and there is a chart like this in the Medicare and You handbook as well, and you'll see it on the Medicare website and lots of other places. So what we're trying to describe is that if you pick Medicare Plan G, it will pay the Part A hospital coinsurance. It will pay the Part A hospice care coinsurance. It will pay the Part B coinsurance. It will pay for blood that you need in the case of a transfusion. It'll pay 100%. The little check mark means that 100% covered by Plan G. And then if I read down a little bit, it will pay 100% of skilled nursing facility care. It'll pay 100% of the Part A deductible. It'll pay 100% of Part B excess charges. It will not pay the annual Part B deductible. None of the plans that are currently available to the general population pay the Medicare Part B annual deductible. That's what's different about Plan F, like Frank, compared to Plan G, like Giraffe. So if you were Judy and you were saying, I don't know, Plan F, should I stay there or should I go get a Plan G? In terms of your benefits, the only thing you're trading off is that Part B deductible.
Which
right?
is $257, is that right?
It is.
Hmm.
For 2025, because that number moves just a little bit year to year. But for 2025, the difference is $257. So you could kind of do the math.
Right.
Depending on which company you had now, you could say, gosh, if I think about if I annualize the difference in the premiums, is it more or less than $257? And
Okay.
if it's not, then you might say, well, gosh, I'll just go to Plan G. And if I have to come up with $257 at the beginning of the year, it'll be worth it. Because that's the only difference, right? And that really, for me, today, the purpose of sharing the chart with you is just so that you can identify, again, that a Plan G is a Plan G, regardless which company sells it. And you can compare, okay, what's the difference between G compared to F, compared to C, compared to N? That chart is meant to help you understand, essentially, it's either your liability or the company's liability, right? So who's responsible after Medicare, you or the company?
And then if I decided I wanted to switch, can you just do that once a year?
Great question. So also a question you're going to get all the time from your beneficiaries. So these plans, again, because they're not contracted with Medicare, they do not follow those same rules about Medicare open enrollment. So if you had, and again, I'm not meaning to pick on anybody, but if you had a Plan G with USAA and you decided that wasn't for you, you can switch to a Plan G with United Healthcare anytime. So it's not related to open enrollment.
Thanks.
Yep, and in Washington State, you're allowed to do that. Again, this is a place where Washington State laws are a little bit different, but you could just say, hey, you know what, I'm gonna apply to switch from USAA to State Farm, and I'm gonna go ahead and send in my application paperwork, and I wanna do that for the 1st of April.
So these supplemental plans, are they national or are they by state?
So they're both, right? So there are some companies that sell in all the states and some companies sell in some states, but not in other states.
How do you find that out?
Ask Linda.
Ask Linda.
I think you have to go to each state to see what they have.
Okay, I was teasing. Don't ask Linda.
You
Yes,
can go to Medicare.gov.
You can go to Medicare.gov. Every state has an insurance department, and every state then regulates the Medicare supplement plans in their state. So you could say, right, hop on the internet and say, which are the Medicare supplement plans that are sold in Kentucky and how much do they cost?
So if I only want ones that are sold in every state, in case, because I don't know where I might travel or something.
You don't have to have it. it will go with you. As long as you have it here, if you're in Arizona, it's going to cover you in Arizona.
It is?
It is.
Okay. That's helpful. Thank
Yep.
you.
Yep. The
Mhm.
nice thing about these plans is no network. So you buy it in Washington because you live in Washington, but it travels with you any place around the country. So any doctor that takes Medicare will take the policy that you bought in Washington. If you move to Kentucky, then you can decide whether to keep the policy you bought in Washington or buy a policy in Kentucky from that company or a different one.
Because it might be cheaper in Kentucky or it might cost more.
Okay, I get
But
it.
you don't have to change just because you moved, right? So again, not meaning to draw too fine a distinction, but this is one of those ways in which the Medicare supplement plans are different than the Medicare Advantage plans, right? If you were living in beautiful Bellingham, Washington, and you decided that you wanted to relocate to beautiful Lexington, Kentucky, you could not take your Medicare Advantage plan with you. You moved out of the service area, they would require you to pick a new company. Or that company, you could keep that company, but you would have to reapply and you'd have, right, different provider network, different rates outside.
Do
But
you have
this
to go
plan
through,
works any place.
do you have to go through that thing where you physically qualify if you moved?
Go ahead, Linda.
Oh, so what I wanted to say, the biggest thing is when you're switching plans with a Medigap is that you don't want to cancel the Medigap you have until you have the new one in your hand. So as long as you have it continuously, then there's no underwriting. You're just switching from plan to plan. But if you take a break, if you let it cancel, then they can
Right.
underwrite you. So don't ever cancel your Medigap until you have your new whatever it is you want in your hand and it's active.
Okay. Good helpful information. Okay.
Yeah. So Linda, let's just talk through that sequencing. So if Judy said I had Medicare Supplement Plan G with USAA, and then I said, gosh, look, United Healthcare has the same Plan G that costs $20 less, then what you would tell her is it's the 27th of February, go ahead and send your application. And then when you get a confirmation back from them that you've been accepted, then go ahead and send them the first month's premium and cancel the other one.
Okay.
Correct. Yeah, the worst case scenario is you end up with double coverage for a month, but that's the worst case scenario. Or I mean, yes, that's the worst case scenario is you've ended up paying twice. But what you don't want is because if you have that break, it can screw everything up. So you just don't want to risk it.
Okay. Great.
Quick question on that. Does each carrier do their own medical underwriting, or is that a Medicare thing?
Go, Linda.
Oh, it's each carrier. And
Oh.
they underwrite different things. So when you go around to, if you're having to be underwritten, so you're doing this outside of when you get a guaranteed enrollment, you can apply to multiple companies at the same time. It's kind of like throw it at the wall and see which one sticks, because they ask different questions and they have different concerns. So one may take you, another may not. Another may say yes, but with pre-existing conditions where there's like 3 months that they won't cover anything that they consider pre-existing. So there's different rules and regulations outside of that, but they do it differently. So you absolutely can try. But once you have one and it's in force, then you can switch companies without it being a problem because they don't underwrite you. You have an
Once you
active
have one.
Plan G,
Okay.
right? Then you can go to another Plan G and there's no underwriting. But if you let it cancel, they can. That's why never cancel your plan until you have the new one that you want in your hand and it's in force.
Good.
And as I said, today is just kind of like getting acquainted, right? So we're going to have lots more programming about Medicare supplement plans. I think I've written in draft form like 6 or 8 follow-on programs that describe each of these things in more detail for you that will give you a chance to learn about it and ask questions and practice with it. But all your questions are welcome today. But really for today, the focus is like, imagine Carrie is just turning age 65 and she is retiring from her job and she doesn't have an option to continue her benefits. And she really doesn't want a Medicare Advantage plan for some reason. We just want to be able to say, sure, there's lots of great options in Washington. These are the companies, these are the rates, this is what each one covers, here's how you apply. If you do it in the first 6 months, you won't have any issues. But you're absolutely right, because Carrie is immediately going to turn to, well, what if I don't like it? What if I pick the right one? What if the rates change? What if that's immediately what comes after it. But if we can just get Carrie started, then that's a good outcome. But all great questions, for sure. Okay, let me see. And Linda, thank you for your help. Maybe, Linda, you should say something maybe about your background experience. How come I'm picking on you as my Medicare supplement expert?
Because before I joined the Sheba team, I was in consumer protection on the L&D side where they regulate the plans. So I have some experience regulating or handling the complaints that people had against the Medigap companies. So I know the rules.
Know the rules. And I'll put a note
And the
in the chat.
policies and the, yeah.
When Linda says LND, she means life and disability.
Oh, yes. And yeah.
PNC, property and casualty. We've kind of divided the world in terms of developing this deep subject matter expertise. But Linda can do both. She can go both ways. Okay, am I sharing my screen? Are you seeing like a horrible blurred image of a booklet?
Yep, we were, it went away.
Okay, so this is a really good resource that we have for you. It's called What You Need to Know About Medigap or Medicare Supplement Plans. The print version is a little bit in revision right now, but the online version is available. And again, if you want to do some self-study, it's a great way to get a review of a lot of the concepts that we talked about today. And in the back of the book, there's kind of a review about some of the things that we talked about relative to switching plans, how that works in Washington State, and the references to the statutory language or rule language that describes what's true in Washington. So I would certainly recommend this to you. Again, works for beneficiaries, works even better for volunteer advisors. And so let's see if we have a volunteer who would like to talk about their experience of Medicare supplement plan. Judy, I know that could be you.
I've already spoken.
Do you want to share anything about like pros, cons, what you like about it, why you picked that?
Well, I really like that I don't get lots of little bills, co-pays and all that. It makes it so much easier to go to the doctor.
Yep. Karen, you used to be a Medicare supplement plan person.
I did.
What do you want to share with us about your perspective about being a owner of a Medicare supplement plan?
Well, I think that it's a wonderful thing, but you have to choose your alpha correctly. And it doesn't have, MedAdvantage does have extra benefits, but you also have, in some instances, more copay, like for a hospitalization or whatnot. But a Medigap policy just doesn't cover any of those little extra things that you get on MedAdvantage. And so I'm trying it this year because, we have the open enrollment again next year, and I'll see how it goes. And I I do know that I did try one of the alphas that was cheaper. That was L. And that's where you find out what the providers are actually charging. Because you have to pay, you know, your half of the 20%. And so that's where I got acquainted with the critical access hospital situation.
Yes. That was a painful acquaintance.
Yes, it was. And especially since there's an acute access hospital 3 miles away across the border. And the federal government, when they set up this critical access hospital business, did not consider anything with that, you know, beyond a state line. And I think that is a big loophole that the Medicare needs to close. There, I've said my.
Okay. All right. Well said by you. Well said. And now, as I said, I will, when we get to the end of the day, I'll help connect the dots for people that don't know what you and I are talking towards. But I think between you and Judy, you've done a really nice job of kind of encapsulating what we end up with in the conversation a lot of times with people where they're kind of weighing and measuring, should I do this or should I do that? So I would say what you hear from people who have Medicare supplement plans is, yes, it's an expensive premium, right? $240 a month for a Medicare supplement plan G, but then I know that after that, everything is taken care of. So I don't get a copay, a co-insurance every time I go to the doctor. I know with certainty that all I'm going to be responsible for things that Medicare pays for. Medicare pays first, my supplement pays second. I don't see a bill. Everything is taken care of. It's like no surprises, very predictable. People really like that about these plans. They can just forecast beyond my premium. If Medicare pays for it, I don't have any liability. Really, really like that. They also really like that there's not a network. They can see any doctor that takes Medicare in Washington or elsewhere. The insurance travels very easily. So for people that travel a lot around the country or who have a specific provider that they want to see and they don't want to hassle about a network, they really like those Medicare supplement plans. And there's no drama about, is my company going to be here next year? It's all taken care of. And the other thing people like about these is that they can then customize their prescription drug coverage around whatever their specific needs are, right? Because they're generally going to get a standalone Medicare Part D plan, so they can shop from among all the 20 of them or 30 of them that are available. So they really like that about that. On the downside, it's a $240 a month premium. And for a lot of people, that feels really out of reach. That's a lot of money. And there's going to be people who are resentful, like, I spent $240 a month for 12 months and never used it. What do I have to show for it, right? That can kind of stick in people's craw a little bit. And then people are also going to say, but what about all those things that Medicare doesn't pay for, vision, hearing, dental, prescription drugs, right? Like, I want that to be part of my package. And some people are going to say, I don't like having a Medicare insurance plan and a Medicare supplement plan and a Medicare Part D plan and then a dental plan and then a vision plan. They want everything to be encapsulated, right? And then on the other side of that, the people that have Medicare Advantage plans are going to say, I love that it's a zero premium. And if I don't use care, it doesn't cost me anything more than that. And everything is taken care of for me inside that one system. But on the other side, then they're going to say, but I don't love that there are these restrictions in terms of a provider network. I'm frustrated, right? As Randy said at the top of the call, denials, delays, prior authorizations, referrals, the lack of clarity sometimes about is something covered or not. So there are good arguments to be made both directions. And in terms of the trend, right, the trend is that more and more people are choosing Medicare Advantage plans for whatever reason. That's definitely the trend about where it's going. And as I said, there's also just a lot of turbulence right now about how those plans show up in the market and how people experience them. So I would say that it's just a great time to become a Sheba volunteer, because you'll have tons and tons of great conversations with people, and you'll learn a lot both about Medicare and about how to help individual people, right? So I'm going to come back to that concept of like person-centered counseling. So there's absolutely nothing different about a plan G, but if I'm talking to Rosie compared to Kendra, compared to Shannon, I'm gonna adjust kind of my conversation or the dialogue with them to make sure that it makes sense for them, right? So I hope that you find it to be super rewarding. We do, and I hope that that's your experience as well. And beyond the complexity and the challenges of learning, it's tons of fun to help people solve the problem that they're trying to solve, I think. Okay. Oh, Linda?
I just wanted to ask Karen real quick. Did you say that, did you have a Medicare, Medicare supplement last year?
Actually, I did, but it was Plan N last year. I've been around the alphabet.
Oh, okay, but you did have, so this is the first year you've had the Medicare Advantage plan.
Well, no, because originally, when I became eligible for Medicare, I had the Regents Med Advantage. So that was a question, because I know you have those first couple months option to opt out and go back to a traditional supplement, but it says first time. So my guess is that's the if you've had it before, too bad, right?
Yeah. Okay. I just wanted to check. I didn't want you to lose an option that you had,
Okay,
perhaps. I
thank
just
you.
wanted to make a note. Okay. Thank you.
You understand that exactly right, Karen, and that is another confusing sticking point for people. Yep. And that book that I had the blurred image, apologies, I'm sure Eva will clean up my next version of the slide deck. We can get you a cleaner image, but that book does a nice job of explaining what you're describing. We call the trial right period. So it explains about how the trial right period works. But you understand it exactly right. Okay, I'm going to shift now, and I'm going to try to do in 45 minutes, 3 short programs. I promise not to rush through it. And again, we'll come back to this lots and lots of times, but I want to talk about financial assistance programs for people who have Medicare. And I'm going to start with what we call Medicare Savings Programs, or MSP. And let me catch up to myself in terms of my workbook. Bear with me here a second. I have not printed my current workbook, so. Okay, so Medicare savings programs are a form of Medicaid, and they're a form of Medicaid that I'm going to refer to, as you can see on the screen, as partial benefit compared to full benefit. I'm starting with Medicare savings programs because this is going to be the thing that you experience the most as a SHIBA volunteer advisor. And it's the thing that you're most likely to convert people who are not currently enrolled. You're going to help them to get enrolled into these Medicare savings programs. So Medicare savings programs are a kind of Medicaid program that are for Medicare beneficiaries who have relatively low income. Important distinction here is that these programs do not consider assets, only income. So you'll know from past experience or from conversations with other people that it's true that lots of other kinds of Medicaid programs, we care about income and assets, or you'll hear income and resources or income and savings. But for these programs, we only care about monthly income. And as we talked about yesterday, yes, there are rules about which is countable income and which is not. I'm calling these Medicare savings programs partial benefit Medicaid to distinguish them from full benefit Medicaid, which I'm going to talk about in just a second. But regardless whether it's full benefit or partial benefit, these are our dual eligible clients, and they are eligible for those dual eligible special needs plans. There are 4 kinds of Medicare savings programs. I'm going to, in this program, just focus on 2 of them, which we call QMB or QIMB and SLMB or SLIMB. No one calls them their real name, which is Qualified Medicare Beneficiary and Specified Low-Income Medicare Beneficiary. You only ever hear QMB or QIMB. So QMB means that the person has the Medicare Part A and Part B premiums paid by the state, as well as Medicare pays the co-pays, deductibles, and co-insurance for any Medicare covered services. So in effect, it acts like a Medicare Supplement Plan G in terms of if Medicare pays for it, your QMB coverage pays for it. SLMB or Slim B only pays the premiums. It doesn't help with any of the other out-of-pocket costs. And there are 13 around the state local area agencies on aging and aging and disability resource centers, and they all employ staff in programs called information and assistance or information and referral, and they're great partners for helping people to understand these rules and apply for benefits. And let me talk about what I'm hoping you'll be able to do at the end of the program today, which is you could explain to people, at least at a very high level, the benefit that they would get by enrolling into one of these Medicare savings programs. You would understand how to help someone find their local AAA or ADRC organization using this tool on the internet called Elder Care Locator, and using a job aid. And I know this is in your packet because we affectionately refer to it as the rainbow chart. So using the rainbow chart, make a quick assessment about whether a person is likely to qualify for benefits, and it's worth encouraging them to apply. So here's my chart where I'm going to kind of consolidate all of the programs that I'm going to do in the next half hour together to give you a sense of them in context. And so these are organized broadly from the highest income down to the lowest income. So in effect, we have this inverse relationship between how poor you are and how much support you can get from the state. So I'm starting with these programs. So again, QMB and SLMB together are Medicare savings programs. They're partial benefit Medicaid programs. The income limits are slightly higher than the full benefit Medicaid, but slightly lower than the limits for extra help. So just to give you a sense of context for those. So again, what I'm saying is that this is my expression for it that I call like the deserving poor. So the more poor you are, then the more benefits that you're going to be entitled to, but you're going to have to prove to us that you're eligible for these benefits. So Medicare savings programs, excuse me, like all Medicaid programs, are funded about 50-50. I'm taking some license there. It's not exactly 50-50, but essentially a 50-50 split between federal funding and state funding to pay these Medicare related costs. So SLMB, again, we say Slim B. It pays the Medicare Part B premium. So in other words, a person who qualifies for the SLMB program, they would have the money put back into their Social Security check. So we would not take the $185 out of your Social Security check if you apply and qualify for SLMB. And the income limit is 110% of the federal poverty level guidelines. And although those guidelines change every year in January, our state puts them into effect in April. So starting in March, the state will be using those new guidelines for making eligibility and enrollment determinations starting April 1st. And so what you will witness from us is kind of a broad-based campaign to tell people about these programs in case they're eligible but not aware, which is a fair number of people. So you'll see we'll have kind of like a marketing, if you will, campaign. I'm trying to stay out of it. This is not my best thing, but it's going to be something like, hey, times are really tough and you might be able to get some help with your Medicare expenses. Why don't you call a Shiva volunteer and ask them to help get you enrolled? Clearly, this is not my best thing, but that's the gist of it. So for QMB, then, it's like SLMB, so it pays the Medicare Part B premium. In addition, then the state would pay your deductibles, co-insurance, and co-pays for Medicare Part A, Medicare Part B. And I can see now that I'm wrong again because I have the same 110% for QMB and SLMB, And who wants to help me? Is the right number 135 for SLMB? Who has their rainbow chart right there?
It should be 120.
120 for SLMB, 110 for QMB?
Mm-hmm.
Dang it. And then 135 for QI1?
Yes, 138, right?
Thank you. Yeah, 138. Yep, because we moved it. All right, friends. Eve, I'm looking at you. I need you to help me here. Get my slides in order, please. And it's not so important about the details, just as much as that you apprehend that there's help for low-income people, and it's dependent upon their income. So let me talk about Medicare savings programs relative to other forms of insurance. So starting with Medicare savings programs and Medicare supplement plans. So a person who has a Medicare supplement plan can be enrolled in SLMB, so they can keep their Medicare supplement plan and have the state pay their Part B premium. But if you have a Medicare supplement plan and you become eligible for QMB, then you're going to suspend your Medicare supplement plan for 24 months, right? Because the state is taking care of the exact same costs that your Medicare supplement plan is taking care of. So conversely, if you already have a Medicare savings program, QMB, then the insurance company cannot sell you a Medicare supplement plan. So when you're completing your application for a Medicare supplement plan, they're going to ask if you're receiving any form of assistance, and they cannot sell you a plan if you already have QMB coverage. With regard to a Medicare Part D drug plan, people who have SLMB are automatically eligible, we say deemed eligible for extra help, as well as people who have QMB. If they have a standalone Medicare prescription drug plan, they will qualify for extra help with their Part D drug costs. How about Medicare savings programs and Medicare Advantage plans? A person who has SLMB or QMB will be eligible for these specialized plans, again, that we call dual special needs plans, or DSNP, we say. A DSNP plan is a kind of a Medicare Advantage plan that is intended specifically for a person who is a low-income person. And if the person has a Medicare Advantage plan that includes prescription drug coverage, then they will have an enhanced or a modified prescription drug benefit inside their Medicare Advantage plan, so that it will have a zero premium and a lower out-of-pocket cost for brand name and generic drugs. So they can keep their Medicare Advantage plan, or they can keep their Medicare Part D plan if, they can keep their Medicare Advantage plan or keep their Medicare Advantage prescription drug plan if they started there and then became eligible for benefits. So nothing about getting eligible for benefits would affect your current enrollment, but it would open up other opportunities for you to have a plan that cost less and had better coverage. So back to that screen that I showed you a little while ago about what we're talking about when you're using the Medicare Plan Finder tool is this radio button that says, I have a Medicare savings program. That's what they mean. They mean QMB or SLMB. And by checking that box, you would see different options than someone who didn't check that box. And you would see different prices. I'm going to skip past employer group health plans and talk about that when we do a program on employer group health plans. So again, I want to make you aware of, if you're not already, our partners at the local area agencies on aging or aging and disability resource centers. They have staff in these programs that they call I&R or I&A. And you can use this link that we call the Elder Care Locator. And I'm going to try to remember to change my screen for you. All right, so here is the Elder Care Locator. And I could put in my zip code for Olympia. Nope, that was too bad. Let's try that again. 98501. Really? It's not going to work. That is so disappointing. 98501. I swear that's where I live. How come that doesn't work? Karen, what's the zip code where you're living?
99403.
99403. No, I wonder, is something wrong with the website?
Well, someone on the CE this morning, someone was having trouble with it. I wasn't, but one of our participants was.
Yeah, mine's
Okay.
working right now.
What the heck? It's just me?
I think Doge shut it down today. I'm just guessing. I don't know.
Well, in
Too
real life,
soon.
You might have to
Too soon,
clear your
Wendy.
browser cookies or something.
oh, okay. Well, you try at home and see if it works for you. But that's supposed to work. It's supposed to say, you live in Olympia. Your local area agency on aging is the Lewis Mason Thurston area agency on aging. But they're a great resource. So again, what's your job as a SHIBA volunteer? Make sure people understand their rights, options, and protections, including that they shouldn't be paying more than they have to for their Medicare benefits. So we want you to be deputized to go out there and tell people, hey, you know, there is this support. You know, times are tough, and getting another $185 back in your Social Security check might be important to you. I can help you understand the rules and get enrolled. So I want you just to think about, how would you go about explaining to someone what they would get if they enrolled themselves into QMB or SLMB? How would you go about kind of persuading them that it's worthwhile to apply? Anybody want to shout out your sales pitch? Kendra Diorio, you're a natural salesperson. It is all about what their needs are. It sure is. And I think that's what, that's how I would sell it to people.
So can you rephrase it for me so I can understand what you want me to answer?
Yes, of course. Thank you. Thanks for being willing. So for me, the question is like, how would you would you approach a client that you are working with, and how would you say, hey, Tim, you know, I want to make sure you're aware that this program that the state offers, that the state will pay your Medicare Part B premium.
So recently I had a couple come in who were both in that scenario where they were, they didn't even know what they could get, what their benefits were. And he was on full benefits, and she had just lost her benefits. And she was like, I just need you to help me sign up for Medicaid, and I'll take whatever plan I can get. And so I started to look around and see what I could do for her. And it wouldn't let me help her in Washington Health Plan Finder because she was Medicare. And right now, the systems don't all talk to each other. And so I went back downstairs and I was like, can I ask you a few questions? And my questions that I ask are normally very different from what I see in front of me. So age, brain injury, there's all kinds of things that might happen that I can see just by sitting down with someone. And then I ask the questions about, can you explain to me your SSI benefits? Are you on LNI benefits? Are you unemployed? Is your spouse unemployed? Is your spouse on Medicare? Is your spouse have SSI benefits? So really for me, there's so many things I can do to get it narrowed down to what they need.
Mm-hmm.
Sorry, that's a lot of information.
No, that's perfect. That's perfect. I would say that for me, it's just about asking them something like, what would you do with another $185 a month?
Yeah. And they were so happy. You mean you can get somebody to pay my premium for me? Well, yes. Because of your income that you're telling me, we can apply and they'll pay your premium and you'll get to keep more of your SSI. And so it's really about getting them to want that extra money back again.
Yeah, and for me, it feels like a lot about what would you do with it, because they just can't imagine having it.
I have a question.
Please.
So,
Yeah.
say that
They can't even.
$185, puts them in one category.
Yeah, they can't even.
$185 less puts them in a different one. How do you reconcile that?
That's a great question, Karen. That can happen, and I would say there's a long list of like objections or concerns that people are going to bring you, and that will be one of them. So you're going to hear, pretend I'm helping Kendra, and she's going to say like, "Wow, Tim, that sounds great. If I had another 180, I could take my daughter and my granddaughter out to dinner once a month. That would be beautiful. But now that I think about it, will I lose my housing subsidy?" That will happen. And the answer is no.
Oh, okay.
Another one that you're going to hear is, well, Tim, that sounds great, but I know somebody who knows somebody that got Medicaid and the state took their house. And like, nope, that's not going to happen either. So you will hear all kinds of reluctance, right? Or resistance, or I had that benefit once and they took it away from me and I still don't know why. And that was very upsetting and difficult. And so you again, back to this idea of like person-centered counseling and a 45-minute appointment, that sometimes people just need to tell their story and kind of unpack some of the mythology that they have about this or the misunderstanding that they have about this, because there's just thousands and thousands of people that qualify that are not enrolled, and having that $185 would make a big difference in their life.
Is there a place that answers those questions? Is that brochure that you spoke of something you could show somebody that says, no, they won't take your house, no, they won't do this, that, or the other?
Yes, and that is especially what the folks who work at the AAA are good for, because they understand all of those rules.
At the what? They work where?
The elder care locator that didn't work.
Oh, okay.
So where you live in Bellingham, Judy, that would be Northwest Regional Council.
Okay.
Uh-huh.
The AAAs, it stands for
Area Agency on Aging. And people like Kendra who work with the tribes or work with Native programs, they're also very good at these kind of the rules. And I'll put we'll see if the slide deck is going to work. Apparently, maybe not 100% of the time, but here is the brochure potentially that the Healthcare Authority has. The Healthcare Authority is our state Medicaid agency. Linda, are we together? Can you see my screen?
I can see your screen, but all I can see is the link. It's not showing if it went somewhere. I'm not seeing what you went.
Okay, thank you for that. Let me see if I can catch us up again. I'll show you the brochure that so in Washington State, our Medicaid agency is the Washington State Healthcare Authority, and this is the worksheet that they have. So you could be eligible for QMB as a single person if your income is less than $1,506 a month, and you can see that it changes in April. And then on the next page, how do you apply? And I like this application form, the one called WashingtonConnection.org. Have you used that one, Kendra? Kendra D?
What about Idaho? Because I'm on the border here, and a lot of people are in Idaho.
A lot of people are in Idaho. Yeah, so great question, because the rules are different state to state. Yep. So the guidelines about income are standard across the country. So all the states, right, again, because it's based on those federal poverty level guidelines, that's the same, but some states consider assets and some don't.
Oh.
And I don't remember now where Idaho is. Does anybody know where Idaho is on that question? I think Idaho still considers your assets, but I could be making that up. Karen, that might be a little homework assignment for you and me and my friend Noreen to check out. But Idaho does have their own area agency on aging network. And you could check in with our friend Kathy Robinson down there or Jeanette, and they will know.
Yes, I do work with that website. Sorry, I couldn't get my microphone on.
Yeah. So how do you find it? And be honest, I feel like it's pretty easy, but you tell me your real life experience.
Sorry, I had to go outside. My son just walked into the house.
That's
and
okay.
was talking to his dad. Say the website.
I'm trying to ask you about using that WashingtonConnection.org website. How long would it take you front to back to help Linda apply for benefits?
So right now, I can do it in about 15.
You're faster than me.
Maybe if I have all the information in front of me with no lag in the computer, and I mean every bit of information I would need in front of me, maybe 10. But that means no snag in the internet, nothing.
Okay, you're faster than me. It takes me about 25 minutes.
Now, I only because I do this sometimes 5 times a day. And then I do have phone numbers when I get in a glitch that I call. I have one direct line to someone in Indian Health that if I have an issue, I go directly to her, and we usually can navigate and get it fixed really quick.
Okay, I don't do 5 in a month, so you're fast.
Sorry. It's fun though. I love it. And now that we're going to integrate with Medicare, March 17th to the 20th, hopefully it'll make it even better.
Let's hope.
Yes, let's hope.
Let's be hopeful.
I know, I'm very hopeful.
Yeah, I like that about you. Okay, so 20 minutes to go. I'm going to use about 10 of them to talk to you about the Extra Help program, and then I'm going to give you 10 minutes to talk among ourselves kind of about next steps and where we're going. And thank you for showing up for a couple of days. So let me see if I can navigate my way back to my little slide deck. Linda, can you see that screen? Linda, are we still together?
Yes.
Are we on Medicare Part D Extra Help?
Yes.
Okay, so let's talk about Medicare Part D. So now I'm talking specifically about Part D, the prescription drug benefit, and this thing called LIS, Low Income Subsidy, or Extra Help. And again, I'll give you just a brief review for today, but I'm going to try not to rush through this. So Extra Help is a benefit for people to get help from the Social Security Administration. And I'm starting from here because this program really is, Karen, across the whole country, all the states, same standard. This is the program that considers assets or resources, but not all assets or resources are accountable. And this is not Medicaid now. So I'm flexing from Medicaid away to not Medicaid. These are not dual eligible people. So this is at the highest level of help that's available, so people can still get help even if they make more than qualifying for Medicaid. So this program is administered by the Social Security Administration. A person can apply for Extra Help at any time. It does not have to relate to the Medicare open enrollment. It works for standalone Medicare Part D plans, as well as Part D plans that are integrated into Medicare Advantage plans. What it means is that you have a lower premium and lower cost sharing, so deductibles, copays, coinsurance for your drugs than other people who are paying the market rate. And because these are not Medicaid programs like the Extra Help programs, the QMB, SLMB, there is no estate recovery, right? So the state is not coming after your house while you're alive or after you're dead. So I'm going to try to then put this in context. So full benefit Medicaid, again, that's our lowest income earners. Partial benefit Medicaid, those are the folks we just talked about. They're kind of our middle income earners. And then extra help administered by Social Security, they're still poor, but they're relatively high income earners. So the difference between these two kinds of programs is that at this higher level of income, we do consider assets, where at this middle level of income, we don't. And again, this is what the rainbow chart is supposed to be helpful for you. Again, it's the same level of qualifying income around the whole country. And so it's set at 150% of the federal poverty level. So for a single person, $1,752 a month. And in terms of assets or resources, $17,220. And again, we have like countable income and countable resources. And the Social Security website has a terrific review about what counts as income and what counts as assets, and all the documentation. As Kendra said, it's great if you have all your documents together before you hop on the phone or before you hop online. So what I'm trying to represent here is, here are those Medicare savings programs where we don't consider assets. And then here at this higher level of income is where we do consider assets. And then again, the income and asset limits. And this is for, I guess it really means the first part of 2025 as well as 2024. So we'll see these numbers all move up a little bit starting in April. So again, extra help works in original Medicare for standalone plans. It also works for Medicare Advantage plans where the prescription drug benefit is integrated into the plan. So you can apply for extra help whether you're getting benefits from original Medicare or from Medicare Advantage, and you don't have to do it when you sign up for the plan. So if you just became aware of it now, but you've been enrolled for Medicare for 5 years, no problem. We can hop you in next month and your benefits will change next month. So you don't, again, it's not a thing where you have to wait for the next open enrollment period. It's just whenever it comes to you that it's a good opportunity to apply, then it's a great opportunity to apply. So what we mean about enhanced benefit design is that you'll have a zero premium if it's a standalone plan. You'll have a zero deductible compared to the standard deductible of $590. And there's a limit to how much you'll pay at the pharmacy. Again, we're talking about inside the network for your plan. So that's why it says participating, because different rules if you go outside your network. But in your network with extra help, $4.90 for a generic drug, $12.15, and this is the cap. It could be less, right? So what we're just encouraging people is like, hey, you might be paying more for your Medicare premiums, or you might be paying more for your drugs in the Medicare program. Let's take a look at, can you get some extra help with those costs? And we can help you to apply for that. And then, as I said, you have in your packet our affectionately called rainbow chart. So that one that you have is good for one more month. And then we're going to give you another one for April. It talks about the eligibility criteria, the benefits, and then a link to more detailed information about Medicaid, Medicare savings programs, and extra help. And yours looks something like this. And I'm not going to test my luck with the link, but we have this website called the MyShiva website where we have all of the resources that I showed you today are stored out there. So you can reach out to Linda or Rosie or Shannon, your our trainer, and they can help you find all of that stuff. Here's a link. Again, I'm not going to test my luck, but there's a link to the Social Security website for applying for help. And what I really like is it has a list of, these are all the things that you should gather together so that this can be a good experience of you in applying. It's a good chart, and it answers a lot of questions about what counts and what doesn't. And then here again is my reminder to encourage you to help people who might be reluctant, because there is a lot of mythology out there about this thing called estate recovery, and it does not apply to any of these programs that we're talking about today. So that should not be a barrier. And from my perspective, and Kendra D, that's how I'm going to call you now from now on, Kendra. From Kendra D's perspective, the application itself is not super difficult. So a lot of people can do it by themselves, but as a SHIVA volunteer, you can absolutely do it for them with their consent. You can actually go all the way to pushing send to send their application over to the state. All right, that's not bad. Let's take a couple of minutes to check in. Tell me, how are you after 2 days of super intensive training? And what are some outstanding questions that you want me or other people to answer today? And what can we help you to do with your next steps in terms of getting integrated into your local group? Who would like to start? Randy, let's start with you. How are you doing? How has these first couple of days been? I know you said yesterday you're like a big picture person. It takes a while to synthesize, integrate.
Yeah.
How are you doing so far?
Good. Good. A lot of information. I've learned a lot. I'm sure I have a lot of questions that haven't filtered down yet. I'm eager to go to my local office and sit down with one of the volunteers who's on the phones and just hear the interactions, hear the questions that come up, hear the answers. I'll learn a lot by doing that.
Excellent. And you have a great group there, and several longtime volunteers, Maureen Hill, Bill Hall, have been around for a long time. And they love mentoring people, so they will be excited to see you.
Great.
And here's what I'll suggest, and you can tell Kelly I suggested this. If you haven't already done this, someday when they're serving meals down at the Olympia Center, just go sit with the seniors and just, in conversation, ask them about, hey, do you have Medicare insurance and how is that going for you? And you will learn an awful lot about the kind of support that they want from you as a SHIVA volunteer.
Good idea. Yeah.
Nothing like having lunch with the seniors to kind of open your eyes to the challenges of those are our clients. All right, Susan Friedman, how are you 2 days later?
Oh, I don't want to say it's not overwhelmed, but I mean, you just realize the sheer volume. And like Randy said, I think I'm kind of more of a big picture person too, and I think it's going to percolate. I have one question, but it maybe is like another side question. Like, are there confidentiality or HIPAA issues with what we do?
There is, for sure. So if Eve didn't already send you this, she's going to send you some training about privacy and confidentiality and a form to fill out and send back. But yes, for sure. And you will be surprised. I mean, you might not be, but I expect you'll be surprised at how free people are sharing things with you. Yeah.
Right.
We wish they wouldn't, but they will.
Like, I'm at the gym in Ocean Shores and people are sharing, so much, like, it's an older population and people are sharing a lot that, yeah.
It is just remarkable. We have a person, Kim, that we work with. Her job is about the fraud prevention program. And it is a steady diet of Kim saying, please do not answer your phone. Please do not give anyone your social security number. Please do not tell me your Medicare number. And people will call me up and they'll say, do you want my Medicare number? And I'm like, no, I do not. Please don't tell me. Please don't start from there. Tell me what your insurance problem is. We probably don't even need your number. Let alone their medical history, their personal relationship history.
Right.
They're going to just unpack all of it. Or they're going to not tell you anything, which is my personal favorite challenge. I had a person calls me up, because they got referred because we had a lot of calls, and so I have the referral, right, that I got from, and I call up and I say, this is Tim. I'm calling from the Office of Insurance Commissioner SHIBA program. I had a referral that you were interested. You had some questions about Medicare. I'm like, okay. So my referral says that your name is Susan. Is it okay if I call you Susan? Why do you need to know? I'm like, look, I'm just being friendly. I don't have to call you. I don't have to use your name at all. I don't have to call you Susan, but how can I help you? Well, how do I know you are who you say you are? Okay, well, you can call me back at this number or I'll send you my email. No, I guess it's okay. I do have a problem with my insurance. All right. So you're going to get all kinds. But that's the joy of it. Carrie, how are you? How are you 2 days later?
I'm good. I'm feeling a little anxious because the dog, my dog distracted me once or twice this afternoon, and I didn't get to hear everything that you said about the Medicare savings programs. So
Yes.
I'll just go back and read those again on my own.
Okay.
But I'm excited. Even after finishing up the second day, I'm still enthused and I'm still excited about it.
That is so great. I haven't ruined your enthusiasm for it.
Yeah, no, I'm curious to hear what next steps are. And like Randy said, get connected with a mentor and start to shadow someone perhaps. Oh, and I did want to thank all the other volunteers that shared their point of view. Your real life experience really helped drive home a lot of the lessons and the material. So thank you very much for sharing.
Yeah, for sure. It's the best fun to do it together. Yeah,
Yeah.
thank you. Yep, thank you. What kind of a dog have you got there distracting you?
A husky.
Is he singing?
No, unfortunately she had been sick the past 3 days, and she's starting to feel better, and with that her energy's coming back up.
I'm glad she's feeling better.
Yeah.
All right. Karen, how are you? 2 days on? 2 days in?
I'm fine, thank you.
Yeah.
This part is what I don't know enough about, and this is helpful to go over this and have these charts.
Yeah, thank you. I think I said this before, but probably half of our clients are Medicare and Medicaid and trending more all the time. And largely that's just because more people are, very sadly, like slipping into poverty, but it's also because they're the people that need our help the most. They don't have the, they don't have internet connectivity, or they don't have money, or they don't have an agent or a broker that they trust, or they just got kind of put in the spin cycle in the, bureaucracy. And so it is really important. And thank you for being motivated to learn it.
I'm anxious.
How about you, Judy? How are you? It looks sunny there.
Yeah, sun came out. I still need to learn more about these extra help programs. They're a little fuzzy to me. And I don't know what my next steps are, so I look forward to hearing about that.
Good news, you have Shannon.
Yeah.
Shannon is going to take hold of your hand and walk you into the park.
All right.
We'll set up a time to chat.
Okay. All right.
Also good news is we have a great group of volunteers up there, and really good connections with Northwest Regional Council and Unity Care and CMAR. So you have tons of community support. The senior centers in Bellingham and Ferndale, and I just lost the other one that's out there. What's the other one out there?
Linden?
Linden, right. The people that think they're still Dutch and they wear wooden shoes. No, don't tell them I said that. But they do have a windmill looking thing for their logo.
And many are Dutch descent up there. Yeah. Lots of Van der Woodsens.
Yep.
Yeah.
Yep.
Exactly.
Van der Veens. And,
Eve, what do you have for us?
Hi, yeah, I just wanted to follow up with what Judy had said earlier about next steps. And I had put a little in the chat, but just in case everyone isn't following the chat, I am going to be sending out a couple emails tomorrow. It'll include all the links that we went over, an email about next steps in the process, how to get linked up with your volunteer coordinator, essentially. And then also it'll include a survey about your experience today. So I will be following up tomorrow and kind of providing some guidance and answering some of those questions, hopefully.
Thank you. And Kendra, my friend Kendra Diorio, how are you after 2 days? Was this worth your while? Keep pushing buttons, not mine, someone else's.
Yes. It was very worth my while. I'm very, very excited to get to the next steps. It was really hard for me to get to this step because I didn't know who to talk to. And so I'm so thankful that someone called me back, Tim. And
You're welcome.
I'm excited to be involved in something that I'm really, really passionate about.
I think I'm so excited to meet you. And, you know, I think I told you when we met on the phone that I had been up there, not in Arlington, but in Darrington, working with my friend Tasha over at the Sauk Seattle tribe. And I spent, you know, a couple of days there, and every single person in the tribe, we got them enrolled into one of those Medicare savings programs.
Yep.
Every
It's
single
great.
one after another.
Yeah, it's great.
So,
It's a great thing. I can't wait to see you. I can't wait to meet you. And once I get my boss a little bit more up to speed, I'll ask her to invite you to the tribe. So it'll be great.
yeah, but don't wait. You're going to go help a ton of people.
Oh yeah. Oh yeah.
And I mean, I think I told you 20 years ago, I had a job like Rosie and Linda and Shannon. I was out training, and it was always interesting to me that people would say something like $1,700 a month. There's no one that only makes $1,700 a month. I'd say, well, in the community you live in, there's about 5,000 of them.
Yes. Yes.
And they would
There's
say,
a lot of them.
how would they do that? And I would say, not with dignity.
No. It's really hard, but there's a lot of help out there. You just got to find it.
That's right. And that's you. You're going to go find them and wrap your arms around and love the stuffing out of them.
Yes. I'm so excited.
I'm excited to have all of you. How about for my staff team? Anything you want to say after 2 days of spending 2 days together? I never see you, and then I see you for 8 hours in 2 days.
I think I'll just reiterate what I started with, and that is what an exceptional group this is. And I'm really excited to see how things progress, and excited to hear how everything works through. And I'm hopeful that as we come up on the next open enrollment period, that you're starting to feel ready to really get out there and start helping other beneficiaries. So thank you so much for being here. It's meaningful.
Other folks in my little beloved staff team?
I echo what Kendra said. This is a great group. Really appreciate you all wanting to learn and do this. And, you know, like I was talking about earlier, you know, just if you didn't get it today, that's like totally normal. Like I said, I've watched presentations on these savings programs several times, and I still, you know, don't know everything, but I'm learning where to find, where to go for my answers.
Okay. I don't want to put anybody on the spot. Linda, Rosie, Eve, anything before we wrap up?
No, I think that's good. Great job, everyone. You know, echoing what Kendra and
You're a little faint, Rosie. Lower the boom.
That's because, yes, the speaker is not where it should be. But nope, I think just great job, everyone. Just echoing what Kendra and Janice said. Everyone did a great job, great group. And thank you so much for deciding to embark on this journey where you're really going to help beneficiaries out and really make an impact. So thank you so much. Look forward to seeing you all more in the future.
Yeah, and I'll reach out tomorrow to, like I said, and Just really thankful that y'all are sharing your time with us. So thank you so much.
Mhm.
And that
Linda?
leaves me. I'll just say thanks for coming and you guys have a great evening.
Yeah, and I'll just say, last for me, closing is just to say, I'm really sincere, that please don't hold back. As Eve said, she's going to send a survey, some feedback for today, but we need all of your suggestions. The program in Ocean Shores where Susan lives is very different than Arlington, where Kendra lives, than where Judy lives in Bellingham, or Karen out there in Idaho next door, adjacent Washington, Oregon down there where it's windy all the time. Like it's just like it's a very different program, and you're going to know way more about the clients and the clients' needs and the community partners than we ever will. So please embrace that. We're really counting on you to be co-creators of the program, and don't wait for permission. Just reach out to us and say, I have an idea about how we can make things better. We always want all that feedback. Please. And thank you. And I'm looking forward to meeting you personally sometime soon. Thanks for being here and thanks for doing this.
Thank you.
Thank you.
Bye.
Good night. And I forgot to thank my friends from Globo for transcribing. Thank you, Global Transcriber.
And I think you have to press stop record.
Oh,
I transferred host to you.
Oh, thanks, Eve. Where am I? Stop record. Oh, there it is. Stop recording.